Good morning, everyone. I'm Robert Dempsey. We're here at the University of Wisconsin today. We are having the honor of hosting this combined symposium on CNS primary malignancy. And this is really important topics that are covered, and it represents a phenomenal partnership between the Medical College of Wisconsin and the University of Wisconsin, with Joseph and Mahua together, bring together a phenomenal group of people to work on issues that are of importance to our patients now and into the future. We've had the honor of having this symposium over the past 3 years, and it just keeps getting better. We're very, very pleased at the breadth of the topics that are covered and the breadth of the expertise that's coming together. I think we'll all learn a great deal, but more important, I think these symposia energize us to this issue of malignancy in the central nervous system. Long time this has been considered impossible and extremely depressing, and we're becoming very optimistic and sharing the optimism of the patients and families for their hope for a better future. So I can't thank you all enough for being part of this, nor can I thank our organizers, Mahua and Joseph, enough for putting this together. I think we're all going to learn a lot in this symposium, and thank you for making it better, because this is what our patients need. So welcome, and we invite your participation. Thank you so much.
Thanks so much, Dr. Dempsey. Well, good morning, everyone, and welcome. My name is Dr. Joseph Bovi. I'm a radiation oncologist at the Medical College of Wisconsin in Milwaukee. It's been my pleasure to co-host this event with Dr. Mahua Day for the last 3 years. We are very excited for our panel of discussants that we've been able to collect internationally for our discussion of primary CNS lymphoma. As we were talking before we got started, this is clearly a disease process that poses diagnostic challenges, definitely poses treatment challenges, but with some of the advances in treatment and diagnostic efforts that have been propelled over the last 3 to 5 years, I think we're really turning a page on this diagnosis, and it's going to be very exciting for us to hear from our panel of discussants today, our experts today, about some of these advances and how we are approaching and treating this disease process in a completely different way than what we did in the past.
Hi, good morning, everyone. And I'm Dr. Mahua Day, and I'm a neurosurgeon at UW-Madison. And I would also echo Dr. Bovi's sentiments and would like to welcome all our faculty who graciously are donating their time to discuss this important issue with us and sharing their expertise with everyone in the broader community of neuro-oncology. We record these presentations, and it has been viewed many times on our YouTube channel. So these symposiums are a very good way of sharing knowledge and, like Dr. Dempsey said, generating excitement and hope in the field of neuro-oncology. So I would really like to welcome everybody. And with that, we're still a little early, Dr. Bovi.
Yeah.
I know we're supposed to start at 8 o'clock. So maybe I see some of the faculty who has already logged in, and we would introduce our faculty during their talk. But if each one of them want to say something before we get started or introduce themselves, that would be also great. So I can just go down the list, what I can see on our WebEx. Dr. Wen.
Hello, I'm KW Wen. I'm a pathologist trained in HemPath and also GI path, and have been very interested always studying lymphoma in the CNS. And I think it's a fascinating topic, and understanding the pathologic limitations and new advances in molecular, I think will open a lot of options for understanding the disease process, diagnosing patients, and potentially impact prognosis. So I'm very excited to be invited, and thank you all for having me here. to talk about some of the findings that I had for this disease process, and also just to learn from all the experts here, from surgeons, oncologists, neuropsychologists, and also the social aspect of this disease process. Again, thank you, and I look forward to present my talk in a few minutes.
Thank you.
Dr. Kramer?
Hi, my name is Mark. I'm one of the six-year residents at Wisconsin. First of all, thank you for the invitation and opportunity to present today. I'll be talking about the neurosurgical aspects of CNS lymphoma, and I'll be talking second, so I'm looking forward to it.
Thank you.
Dr. Barajas?
Hi, everybody. Thanks for the invitation to speak. Yeah, I'm a neuroradiologist by clinical training, but a physician scientist as well, supported by the NIH, doing research in brain tumors with respect to imaging and new therapies. Associate professor at Oregon Health and Science University, Department of Radiology, Advanced Imaging Research Center, and the Knight Cancer Center. Really excited about having this discussion today about imaging, where hopefully we are now and where we can go in the future and how we can improve our patients' lives. Thank you so much.
Thank you.
Thank you. And Dr. Chukwueke, I hope I said that correctly.
You did very nicely, Dr. Day. Good morning. I'm Ugo Chukwueke. I'm a neuro-oncologist in Boston at the Dana-Farber Cancer Institute. I work quite closely with Lakshmi Nayak. So I appreciate the invitation to speak today. I as well am hoping to share information as far as the medical advances in terms of management of relapsed refractory primary CNS lymphoma, but also hoping to learn from all the other experts on the panel. So thank you again, and I'm looking forward to this meeting.
Thank you. All right. Well, I think it's 5 minutes early, but why don't we go ahead and get started? Then we can have perhaps more time for questions and for our panel discussion at the end. So
now, it's a great transition to move on to the role of neurosurgery in this. As Dr. Wen emphasized, the tissue sampling is a critical aspect of diagnosing primary CNS lymphoma. And so Dr. Mark Kramer, he's a senior resident at our Department of Neurosurgery, and he's going to discuss the role of neurosurgery in diagnosis and management of primary CNS lymphoma. Dr. Kramer.
Well, thank you. So advance my slides. So these are my learning objectives here. Thank you for the introduction. Again, my name is Mark. I'm one of the six-year residents here at Wisconsin. Again, thank you for the invitation for talking today. So I'll be talking about the neurosurgical management of CNS lymphoma. And to kick things off, I guess I want to start with this. So CNS lymphoma is the third most common brain tumor we find in elderly patients. And this is behind glioblastoma and meningioma. I show a figure here from a paper, it's a little older now, published back in 2016, which looks at rates of CNS lymphoma between 1992 and 2011. And this particular paper looked at both immunocompetent and immunocompromised patients. The solid lines represent the immunosuppressed patients, including those with HIV, and the dashed line represents the immunocompetent patients. As you can see throughout this time period, amongst these different age groups, overall rates have actually come down, and that's primarily due to effective antiretroviral treatment for patients with HIV. However, if you look specifically at the panel I highlight, that third panel over, the patients that are diagnosed with CNS lymphoma in the immunocompetent kind of group are rising, anywhere from 1.5 to 1.7% among men and women. So it is becoming more common, and patients are oftentimes presenting older. This was another paper essentially saying the same thing from a Swedish cohort published back in 2017, again showing even age-adjusted incidence rates, specifically among patients in their 70s, are increasing. So that is all to say that we are seeing these patients more commonly presenting with CNS lymphoma. This is one such patient I took care of a few months ago. So this is a 69-year-old gentleman. He presented with about 1 month of kind of slowly progressive confusion and a mixed aphasia. He underwent initially a CT at a referring center and then was sent to us where we obtained this MRI. And as you can see from the imaging here, there's a solitary mass within the left temporal parietal region. And if you look at the sagittal imaging here, this is a FLAIR sequence on MRI. You can see that the mass involves the kind of dominant supramarginal and the angular gyri. And if you remember back from your neuroanatomy, this is kind of the region where Wernicke's area, this language area, Brodmann area 22, is oftentimes found. So this was the radiology impression from the scan. They actually favored a primary glial neoplasm, such as high-grade glioma. So as is typical at UW, this patient with a new brain mass was admitted directly to us, to neurosurgery. My juniors had already admitted the patient. They had already started IV corticosteroids, which is typical, and we're preparing to consent the patient for craniotomy and tumor resection. I happened to be on call that afternoon, and I was looking through the imaging along with some of my colleagues, and I reviewed some of the clinical information. He's an older gentleman. He's got 1 month of these progressive symptoms. The tumor seemingly in the middle of Wernicke's region, and this kind of cotton candy, kind of fluffy-like appearance with this homogeneous enhancement. And so I pumped the brakes, and I called our staff that afternoon and suggested a stereotactic biopsy. So we did kind of alter the plan, performed a stereotactic biopsy that afternoon with the pathology confirming lymphoma. So as seen in this patient, CNS lymphomas oftentimes appear as solitary lesions, almost 2/3 of the time. They're oftentimes periventricular, owing to and also owing to their hypercellularity. On CT, they're oftentimes a little hyperdense. They had this kind of fluffy cotton candy-like appearance and very classically show this kind of homogeneous enhancement. So dating back to the modern description of CNS lymphoma, specifically from this paper from Henry in the 1970s, surgery has never been a major tenet of CNS lymphoma treatment. Although this was not rigorously evaluated in that initial paper, they did suggest that surgery for anything other than diagnostic biopsy was usually not beneficial. I highlight that in their abstract there. And this is probably in part due to the fact that many of these patients presented with multifocal lesions and or deep-seated lesions, which were not easily surgically accessible. The paper on the right is among the more influential analyses, which also has kind of solidified this modern non-surgical paradigm. This was a large retrospective series of nearly 250 patients in which they showed that surgical resection, even partial resection, was actually an unfavorable prognostic factor in patients with CNS lymphoma. Since this paradigm has been challenged actually on a couple different by a couple different groups. Here's just a few recent examples of this. The paper I point out on the left here was from a German study. It was actually a trial that was initially looking at the role of whole brain radiotherapy in patients undergoing chemotherapy. And in kind of an unplanned secondary analysis, they looked at patients who underwent resection of these lesions, and they found that patients that underwent gross cell resection actually performed better in overall survival and progression-free survival. A more recent paper on the right in a North American database showed something similar. It's also interesting that to point out that many of the cases in which partial or complete resection were performed were often in cases where there was some diagnostic uncertainty, and or there were institutional kind of practices that led surgeons to resect these lesions more often, either to mitigate mass effect or prevent future issues with mass effect. Regardless of this, surgery for CNS lymphoma remains controversial. So the current standard of care remains non-surgical, and therefore the primary role of neurosurgeons is a safe and timely tissue biopsy. We're oftentimes the front line initially evaluating these patients when they present. And it is crucial that we have a high degree of clinical suspicion for lymphoma based upon the available imaging studies. And when we think the lymphoma is on the differential diagnosis, we should hold corticosteroids, and I'll discuss this a bit later as well. And Dr. Wen also talked about this as well. So on the right here is an image of almost 6 residents performing a biopsy. It's a rare occasion from a couple of years ago. In terms of stereotactic brain biopsy, the technique itself actually was initially pioneered in Philadelphia initially, and then kind of popularized and kind of advanced by Dr. Lars Leksell in Sweden. So on the left, I show the Leksell frame, which was one of the initial tools designed to perform cranial biopsies, which uses this center of arc technique. I show this mainly for historical context, but modern frameless techniques are still built on this original mathematical system. On the right is the more modern frameless technique, which is the current standard of care. In this case, we use high quality MRI to upload images to our computerized navigation system, and this allows us to precisely perform these biopsies without applying kind of a burdensome frame. So there are a bunch of different companies that supply this technology for frameless brain biopsies. We happen to use the Stealth system at UW, but again, other systems have very similar hardware and software interfaces. The image on the right kind of shows kind of what the planning software kind of looks like. It's really quite amazing. Unlike previous workflows where there was potentially hours of planning prior to the biopsy, now these systems allow us very rapid planning, almost right in the OR while the patient's going to sleep oftentimes. So in these cases, what we do is we upload the MRI, the high quality MRI, directly into the planning system. We can actually use multiple MRI sequences and actually overlay them on top of each other. And if available, the fusion tensor imaging can be used to overlay the white matter tracks on top of our anatomy scans and allow us to kind of very specifically guide where we're going to place our biopsy site, and then also identify a entry site. And then once we've done that, we can actually use a probe's eye view to just kind of scroll through the expected trajectory and identify any dangerous anatomy as we're scrolling through that path. We typically aim for a short trajectory down for the lesion. We oftentimes also aim to have a longer axis of access to the lesion itself, so that we can gain multiple specimens, both deep, centrally, and more superficially along the lesion. And this is a very, very nice technique. On the bottom left, I show a splenial lesion, which I think everyone agrees it would be a very difficult lesion to access surgically. And with this technology, I point this out here that again, by overlaying potentially the white matter tracks from DTI imaging, along with potentially functional imaging as well, if available, we can very carefully get down these lesions without disruption of these eloquent areas, and also avoid, for example, ventricular system, which also would potentially increase complications. So the technique itself is fairly straightforward. The head is fixated in a Mayfield rigid head holder, as shown on the left here. And then using our navigation system, the arm is, there's an arm that's actually affixed to the Mayfield. And then the navigation system itself updates in real time and provides accuracy in millimeters as we kind of navigate this, this arm to the trajectory that we had previously planned. Once in position, we make a very small incision on the scalp, drill through the bone, and then a needle is passed down to the target where we gently aspirate the surrounding lesional tissue. We typically have a neuropathologist immediately available to ensure the tissue is obtained as diagnostic. This is oftentimes like a squash and print prep. And on the right, I show an image of the typical biopsy needle, which again shows kind of a window which allows us to gently aspirate the lesion into the open window, and then the cannula can be closed and removed to obtain the tissue. Post-operatively, we commonly perform a CT. The right scan is actually the CT that was performed directly after the biopsy on the previous case I discussed. If this shows no significant hemorrhage or even a small asymptomatic hemorrhage, we typically admit these patients directly to the general care floor for observation. And unless there are other issues and they're meeting all of their discharge criteria, they oftentimes will discharge on postoperative day 1. It is important to note, however, that despite its relative safety compared to many things we do in neurosurgery, complication rates are not zero. I highlight one recent paper that showed a rate of symptomatic hemorrhage of almost 2.6%. And again, of note in this particular paper, they were looking at many pathologies, not just CNS lymphoma. But in most cases, if there is a small hemorrhage, these are oftentimes managed non-operatively. And from a technique standpoint, the risk of hemorrhage can be mitigated to some extent by careful planning. Specifically, avoiding large vessels, planning a trajectory through the gyrus instead of through the sulcus. Again, that's where the cortical vessels are going to be running, and avoiding super long trajectories can also be important. And Dr. Wen talked about this briefly, but traditional teaching is that we are not supposed to be giving patients steroids. As I showed earlier, the imaging alone is not always diagnostic. And furthermore, our brain tumors, when we admit them, I show an image of a glioblastoma here on the right. We very, very commonly, it's the first thing we do is we give them a high dose of IV corticosteroids. And this is typically quite helpful. They oftentimes, within as early as 12 to 24 hours, have pretty significant relief as that blood-brain barrier is kind of somewhat restored and some of that vasogenic edema is being treated. But as we know, corticosteroids are toxic to lymphoma cells. And this seems to be mediated through a cytoplasmic receptor, which translocates to the nucleus and induces cell death. So this paper nicely demonstrates kind of the histopathologic effects of steroids on lymphoma specimens. The top two panels show a patient that both an H&E and then on the right a CD20 stain of a patient with 3 days that was treated with 3 days of steroids prior to biopsy. And you can see that very classic histology, but although there's a little bit of cell death within that population. And then looking at the bottom 4 panels, this was a patient treated with high dose steroids for 7 days. And as you can see, with this longer course of steroids, there multiple apoptotic bodies, macrophages in that kind of middle panel there, and it would be a little more, quite a bit more difficult to make that diagnosis. Yet a different section of that same patient, again, shows some of the more classic histology. Ultimately, they were still able to make a diagnosis of lymphoma based on the sample, but you can tell that there's a little more heterogeneity within the specimen itself. This was another study that retrospectively evaluated patients undergoing biopsy for lymphoma, and interestingly, almost 2/3 of them were treated with steroids before the biopsy. They went back and they looked at all these cases, and they determined that about 13 of them required repeat biopsy. And amongst those 13, 8 had received steroids, 5 had not. And they ultimately concluded that even despite use of steroids, they were still able to more or less make this diagnosis, and it did not massively affect their diagnostic ability. So yet, I think it's important that despite these reports, it is still best practice to hold steroids. This is a nice paper that demonstrates that, that there is, at least in their account, at least 50% of patients treated with corticosteroids show tumor shrinkage. This is nicely demonstrated in the top panel there. A patient treated with 8 days of IV corticosteroids on the left and the right, and you can see that there's a pretty significant tumor shrinkage. As I showed earlier, stereotactic biopsy is very precise, and our trajectories are based upon the local regional anatomy around the tumor, and therefore I think it's important that if patients are treated with longer courses of IV steroids before they're sent for biopsy, it's probably best to re-image so that we can again help tailor our biopsy to target the tissues that are obviously lesional. So at this point, you might be wondering, why are patients waiting a week or longer before a biopsy? And I think it's important to note that, at many large referral centers, there's definitely been an increase in demand on their systems. And additionally, even after these patients eventually get transferred to our system, it may not always be easy to add on these patients to the OR schedule immediately for biopsy. So delay in diagnosis can be quite a big problem. And historically speaking, lumbar puncture was indicated in CNS lymphoma workup. Yet, as we've already kind of discussed, the diagnostic yield of many of these studies is very low. Published literature suggests anywhere from 6 to 13% of those specimens will be positive. So it is the last bit here we'll discuss briefly is some of these new technologies which have been used to improve the yield from CSF sampling. So the term liquid biopsy refers to analysis of tumor-derived DNA from patient specimens, for example, blood or CSF. And I know Dr. Wendt touched on this, that myeloid differentiation primary response gene 88, the MYD88, is a very specific mutation for lymphoma. And currently there's a lot of enthusiasm for liquid biopsy in CNS lymphoma looking for this mutation. The paper I show on the left here it was a small study, but looked at CSF collected from patients with biopsy-proven lymphoma, and their yield from very small CSF samples, their median CSF collection amount was only 3 milliliters, was almost 3/4, which is quite impressive. And in those remaining 25%, they just didn't have enough DNA to really perform the analysis. So I think although this technology is not yet at the forefront of diagnosis, I think it will be in the future, and it will certainly probably to some extent displace our our role as the biopsy specialist, if you will. So that is all I had. I will take any questions now or later if we have a few minutes.
That was just great, Dr. Kramer. Thank you so much for sharing that with us. I know this is somewhat of a challenging topic. We don't necessarily talk about extension of or the extent of neurosurgical resection for primary CNS lymphoma, but you shared some very interesting data there. I do have a couple of questions, but we're going to hold that until the end for the panel discussion. And then again, for the rest of the attendees, to remind you to please use the chat box. We can keep track of the questions that are being asked and make sure that those get addressed at our panel discussion after all the speakers have had a chance to talk for this first session this morning. We're going to move on to our next discussant. Dr. Barajas is joining us from Oregon this morning. He's been at the Oregon Health and Science University since 2015. As he had mentioned in his own introduction this morning, he's a board-certified diagnostic radiologist with a subspecialty certificate in neuroradiology. He has research interests focusing on quantitative imaging, genomics, neuroinflammation biomarker development, and molecular radiotheranostic approaches that are translatable for patients with brain tumors. And we're super happy to have him join us this morning. Thank you for getting up early, Dr. Barajas. We appreciate you and looking forward to your talk.
Great, thank you. Hopefully you can see the screen okay. Can you hear me?
We sure can. Thank you.
Okay. All right, well, thank you so much. Yeah, again, I'm going to be, predominantly talking about imaging in terms of patient outcomes for CNS lymphoma. But before we get there, we'll talk a little bit about the biology. So I don't have any conflicts of interest. Thankfully, I do have some research support from the NIH and from some foundational work at OHSU that keep me supported for research. So topics to discuss, like I said, we'll talk about imaging, relevant primary CNS lymphoma biology, what are the current imaging recommendations, and how can they be used kind of clinically, and then what are maybe some future directions that we could think about with respects to imaging and clinical decision making. So you guys have the objectives in hand, I think, so we'll go ahead and leave that there. So I think, as everybody knows here, MRI is the workhorse for CNS diagnosis in terms of non-invasively, right? So, if patients have neurological disorders, we routinely and easily perform MRIs. And the two main sequences that we rely on as radiologists, as diagnosticians, is this T1 post-contrast image seen on the left, and then the T2 weighted image. And these two sequences for MRI are exquisitely sensitive, right? We can detect very subtle abnormalities within the brain and spinal tissues and elsewhere in the body just by way of the way they're acquired and what they kind of mean. But what they're not at all helpful for is specificity. They don't tell us overall much about the tumor biology in of themselves. And oftentimes they don't help prognosticate what's going to happen for our patients. And as you'd imagine, that's probably the most important thing when somebody's diagnosed with a tumor is they want to know what's going to happen, right? And so preoperatively, certainly, and as through the course of therapy, these two sequences are not super helpful. Gadolinium enhanced MRI, we see the brightness in the brain parenchyma, basically because the blood-brain barrier has been disrupted, and contrast can pull in the interstitia. And then on the T2 weighted image, essentially that's just showing us increased water content within the interstitia of the brain parenchyma. So sensitive but not specific. But we also luckily have some physiologic sequences which we know are more biologically specific. That's what's been shown with some of the biological correlations that have been done. Those include diffusion weighted imaging. That's a workhorse for us as neuroradiologists. DSC perfusion MRI, which is a contrast-based perfusion sequence. We'll talk about that. And then also different ways of doing physiologic PET imaging, which can capture different physiological processes depending on the radio tracer. And we'll talk predominantly about FDG PET imaging for this lecture. So start with DSC perfusion MRI. The way this sequence works is we obtain this heavily T2 star weighted image. That just means that the blood, once the contrast arrives, is black. So you can see there that we acquire it multiple times very quickly. And we can actually track the contrast bolus by the signal change, which is the darkening we see there in the vessels and the brain parenchyma. And so from that, we can generate a signal intensity time curve where the time is on the x-axis, signal intensity is on the y. And again, we can just graph the signal change that occurs because of the contrast that's intravenously delivered. And if you do some math of this, you can integrate the area under that curve and basically get a quantitative number. And what we use that clinically is a cerebral blood volume. And what I'm showing on the right is a cerebral blood volume map. And so we generate a color map that shows typically red is going to be higher areas of cerebral blood volume, and black, light blue is going to be lower areas of CBV. And so you can see just in this CBV map alone, there's a very abnormal lesion in that right frontal lobe that has elevated cerebral blood volume. And so that can be helpful in understanding what are the perfusion characteristics occurring within a lesion. Another modality we have, which allows us to capture physiology of these brain tumors, is diffusion weighted imaging. And so from that, typically you'll see two images. One here we see in the middle left is the B1000 image. That's called the trace map. And that's kind of a heavily T2 weighted diffusion image. And because of that, we want to get rid of the T2 signal that's inherently in that image. And that's why we produce the ADC map. So when we say things are reduced in diffusion, we want to see them be increased in signal or bright on that trace map and then correspondingly dark on the ADC map. And diffusion weighted imaging is very, very complicated, but I think, we can use some easy paradigms to understand it. Essentially what we want to do is we want to track the Brownian motion of water. And so from that, we can characterize the ADC metrics. So if this red dot here is a water molecule, and the little seeds here in water on the slide represent cells within tissue, we can track that Brownian water motion. So normally if a water molecule is in an open space, it's going to freely diffuse anywhere it wants to go. And you have a lot of water motion, as opposed to a water molecule that's more defined, confined within a space. It's going to be kind of stuck in that space because it's going to bounce off the surrounding cells. And so assuming it doesn't go into the cell, but that's another story. And so we can actually capture this water motion using MRI, believe it or not. So what we do is we place two voxels, we energize the water, and then we turn on the gradient, and we allow the water to diffuse for a certain amount of time, and then we listen for the signal that comes out as energy that's lost. And you can see the top left voxel, the red dot, the water molecule, has diffused out of the voxel. So when we listen to that voxel, we get very little energy coming out of it. As opposed to the lower right box, the water molecule stays within it, and so we get more energy. And so with diffusion weighted imaging, what we can do is we can vary that magnetic gradient. And that's going to cause the water to diffuse in different directions. And again, we just repeat this experiment multiple times. And we listen for the energy that comes out, which comes out as a radio frequency. And we can understand the amount of energy that's deposited in each of the directions each time we do the experiment. And from that, we generate these trace maps. And that's why the signal is brighter on this trace map, is because there's more energy that we're observing from that voxel, and that's represented as bright. So a little bit of a background on how we form those quantitative diffusion metrics, the apparent diffusion coefficient metric. So next I want to talk about FDG PET imaging. So this can really be a workhorse for us in radiology and diagnostic imaging. It's really eloquent because we can just capture so many different physiological effects depending on the radioligand we use. And the most common one is FDG, but there's other ones that are commonly used. For amyloid, we can use markers to detect that. We can use amino acids to look at molecular synthesis, and so on. But basically what you do is you go into this donut-shaped machine. That's the PET CT on the left. Now we also have PET MRIs that are dual modality and can do MR imaging and PET imaging at the same time. And it allows us to capture these fancy colored images where increased radioactivity is usually darker on the screen or brighter on the screen. And so what I want to do is just kind of talk about the dynamics of this. And so, you know, typically with fluorine-18, it's a radioactive molecule or nucleus that has too many protons in it, and that's going to just naturally undergo beta decay, where that proton turns into a neutron, and when that happens, it releases a positron. Positron is actually antimatter, and so when antimatter collides with matter, it's never a good thing. It creates a lot of energy, and so when that positron hits an electron, it's going to create energy, 511 keV gamma photons that are going to go in 180-degree opposite direction. And we can use the PET detector to detect those two photons and then trace them back to their origin for where they came from. And so that's fundamentally how we form the PET imaging. But I still think it's kind of conceptually hard to understand that. So, you know, you can do some really nice, beautiful experiments where you stick radioactive materials in an alcohol cloud and actually visualize the radiation that's coming off of it. And so that's what this kind of represents here, a video of accessory uranium. And those are beta negative energy that's coming off of it. But we can visually see that through the alcohol cloud. And so, you know, essentially when we give patients radio tracers, this is what their cells that's accumulating it is looking like. It's just all this radiation that's coming off, it's being detected. And that's how we can help understand the physiology a little bit better. As I mentioned, with respect to PET imaging, we can do assess a lot of different physiologic states or receptor statuses, right? We can do hypoxia imaging with fMISO, amino acid imaging, looking at cellular proliferative rates with amino acids. But the workhorse really is FDG imaging, and that's the physiology of that is through GLUT1 transport into the cell. We'll talk about that a little bit here in a second. So, you know, we have all of these imaging techniques that have been developed, but believe it or not, there wasn't until the last couple of decades really a good understanding of exactly what is the biology that's being represented, right? And proven through histopathological correlation. But that's kind of been, you know, worked on, and a better understanding of that is happening. You know, as our previous speaker talked about, you can do stereotactic biopsies in the OR using the neuronavigational devices. And so what that means practically for us, if we want to understand the biology of these new imaging sequences, is we can ask our friendly neighborhood neurosurgeon to collect tissue for us, and then we can mark exactly where that piece of tissue came from with respect to the MRI, go back and get the imaging metrics from the sequence, and then also look at histological images or whatever type of pathological analysis you want to do to define what the biology of the tissue is. And so that's been done in primary CNS lymphoma. And what has been found is that diffusion-weighted imaging does correlate with cellular density, right? So you can have an inverse relationship where lower ADC values have higher cellular density counts, right? So the darker the ADC map looks within the lesion, the more cellular you expect it to be. And so that also pans out to be clinically prognostic as well, because if you use a particularly low ADC cutoff value of 385, you can prognosticate on how patients are going to do, where patients with higher ADC values prior to starting therapy that have primary CNS lymphoma are just going to have better clinical outcomes, as demonstrated with progression-free and overall survival. And so practically what that looks like when we image the patient is, you know, you have these enhancing foci that basically look the same. You know, one on this example is more kind of focal versus multifocal on the other one. But the diffusion-weighted imaging looks very different. And you can see that in the heat map that's produced from the ADC image in the right-hand side, where blue is more reduced diffusion or lower ADC values. And so sampling in those sites, you know, again, shows this correlative relationship between cellular density and ADC values that's, you know, inverse. So lower ADC, higher cellular counts. So that seems to have some sort of non-invasive metric to track clinical outcomes in terms of how they're going to do before therapy. And that's been replicated in patients getting kind of more modern treatments with methotrexate and rituximab. That's been shown by other groups as well, where this different 384 ADC metric is correlative with overall and progression-free survival. So what about our perfusion metric that we talked about? Like I said, we can acquire perfusion maps or cerebral blood volume maps using this DSC technique. This is an example of glioblastoma, where we have two otherwise similar appearing enhancing foci in the lateral margin there. You can see the kind of the purple circle and the orange circle. But the purple region of interest towards the top has elevated CBV. And so if you sample those two different regions, you can see kind of different biology. The higher CBV metric foci is going to have more neoangiogenesis, going to have more dysplastic cells, and then also have higher Chi67 counts, so higher cellular proliferation, as opposed to the similar appearing enhancing spot that doesn't have elevated CBV, or as elevated CBV. So that can be helpful in glioblastoma to really target biopsies for tissue diagnosis and getting the most malignant biology using these CBV maps. But as we know, primary CNS lymphoma is a very different beast than glioblastoma. The biology is fundamentally different, as was talked about. And it's particularly true in its growth pattern, right, being a perivascular type growth pattern. And interestingly, bad actors in primary CNS lymphoma, rather than having elevated cerebral blood volume, actually have low cerebral blood volume. So here's an example on the left. You can see that post-GAD T1 weighted image in a patient with primary CNS lymphoma, big, large enhancing mass. And if this was a primary glial neoplasm, I'd expect the CBV to be through the roof. But in this case, it's not, right? You can actually see, for the most part, it's pretty low. And so a very different pattern we see with primary CNS lymphoma. And I haven't seen a study that's directly looked at this relationship between growth patterns, angiogenesis, and CBV maps. So that's an area of research that still needs to be undertaken. But for the most part, we know that CBV is lower in CNS lymphomas. And that tracks out as well for clinical outcomes. So as I said, patients with low CBV, so the survival curves on the right, the dotted lines, low CBV, those patients tend to do worse clinically as well. They have shorter survival, progression-free and overall survival. And this study also replicated the diffusion characteristics as well, where low ADC values also have poor outcomes. And so what they did was they stratified this kind of into three categories using both of the, or three clinical categories using both of those metrics, where kind of the high perfusion, high ADC patients do best overall. So, useful imaging metrics preoperatively for assessing how patients may do. We talked about also the FDG PET imaging. Like I said, its primary cellular uptake mechanism is through the GLUT transporters, predominantly GLUT1. And it's actually bound, converted in the cell before it enters the Krebs cycle. And so it's really a marker of cytosol uptake of the FDG. And that can be useful because, as we know, cancer cells like glucose. And so FDG also can be a metric of how patients are going to do as well, where lower values, patients tend to do better than patients with higher FDG uptake values. Those patients tend to do worse. But in the brain, FDG PET imaging in the brain isn't ideal. As you can see, there's a lot of background glucose uptake because the brain loves glucose. And so our signal to noise is not so great. We really rely on low background signal and high lesion uptake to be able to distinguish where the lesion is in these types of images. And unfortunately, the FDG glucose just doesn't help us for the most part with that respect. It's a lot of background uptake. So, its utilization within the brain, I think, is still being determined and clinically kind of really undecided at this point. The main workhorse is in systemic staging. And so, here's an example, patient with a brain lesion found to be lymphoma, and then went through, whole body workup. And sure enough, there was systemic disease as well, as seen on the right, kind of the bright foci on the PET CT, and in the middle MIP image, you can see those bright foci. So it was systemic lymphoma with CNS involvement rather than CNS lymphoma. And that drastically alters the care that the patient is going to get. And so despite the low incidence of brain involvement in systemic lymphoma, we still recommend that the staging occurs to look for those extra CNS disease, because that, like I said, that changes the patient's management. So there's been some studies that have looked at this. What is the diagnostic yield of using FDG PET imaging to stage patients? This was a recent meta-analysis that was done. And overall, of all the studies that were assessed, the weighted mean pooled analysis from almost 1,100 patients, it was 1,099 patients from 14 different studies, showed that the overall diagnostic yield was about 6%. And that ranged from 4 to 8% in the study. So like I said, low overall incidence, but it's important when it is present that it's known that it's systemic involvement. So kind of midway through with the talk, kind of the summary, imaging is critical to what we do clinically in the clinical management of the patient. It guides biopsies and it guides systemic staging as well. The MRI, our T1 and T2 weighted MRI sequences are very sensitive at detecting disease, but not necessarily defining the biology that's happening, and as such, not really helpful with outcomes. So that's where we rely on some of these physiologic PET and MRI metrics that we can capture to help understand better the biology that's happening in primary CNS lymphoma, and like I said, may stratify clinical outcomes for these patients before they start therapy. So what are the current imaging recommendations? I've been fortunate enough to work with the International Primary CNS Lymphoma Working Group and help define some of these recommendations. We have an older article from 2005, which discussed some of the imaging parameters that could be used, and then some of the response criteria that could be used as well in helping to understand response to therapy. And then recently, in 2021, we published the consensus guidelines for both MRI and PET imaging for CNS lymphoma, which really lays out in detail the sequence parameters that can be used when imaging our patients. And this ranges from the most high-end academic university setting, all the way to just your common clinical practice out in the community that has MRI machines. And so what we recommend is a pretty standard approach. We provide both an ideal MRI protocol for the brain, and then also kind of a minimal protocol, both at 3 Tesla and 1.5 Tesla. We provide the sequences for that. And we also have some formal recommendations for how to perform the sequences with diffusion-weighted imaging, perfusion-weighted imaging, because there's lots of knobs and handles you can turn for the MRI. And you want those all to be set kind of in a standard way so that we can all compare all of our imaging together. So as such, if you were to take this paper to your friendly neighborhood radiologist, they should be able to just pretty much incorporate these sequences from the paper into their machines. And so when you're scanning your patients with primary CNS lymphoma, you can be kind of incongruent with what the current recommendations are. It's kind of a one-stop shop for radiologist sequence development. So one of the things that we don't commonly do in the community is look at spinal staging. And so the current 2005 recommendation is that staging of the spine, occurs when there's symptomatology related to the spine, right? So you don't really image unless the patient has symptoms referable to that. Just because it talks about the thought to be low incidence rate. So really the driving here is the clinical patient, how they're doing, and do they have symptoms referring to that. If not, you're really only going to be watching the brain, and you're going to stage the whole body with PET, but not really look at the spine. But there's been some recent publications that suggest that the spinal involvement rate may be higher than what was previously thought with primary CNS lymphoma. And this is a kind of a registry analysis looking at cases from 1975 through 2017. And what the data from this paper would suggest is that primary CNS lymphoma involves the spine in approximately 16% of the cases. And so, when we come across these cases at OHSU in tumor board, I do recommend that we look at, we may want to think about staging the spine once we've established that diagnosis of primary CNS lymphoma. But that's not in the prior paper that I talked about. What is in the prior paper is a recommendation for using systemic FDG PET-CT to stage the patients. I know a lot of institutions will just do a contrast-enhanced CT, but this is a great example of why that may understage patients. On the left is the CT with contrast. On the right is the PET-CT without contrast. And as you can see, the nodal disease that's systemically involved here is easily not visualized by that contrast-enhanced CT, but it's pretty obvious with the FDG PET. So, why oftentimes the CT alone is good enough. For the IPCG recommendations, we do suggest using FDG PET to stage. So, question is, which modality do you use? Like I said, most everybody is going to have a PET CT, but I really like the PET MRI. We are fortunate enough to have one at OHSU. So I really like seeing the systemic staging and brain imaging all kind of done at once if we can for our patients. It's really is easier for the patient. It's kind of one-stop imaging for them, right? You don't have to come in for your brain MRI and or your spine MRI, and then separately go and get a CT with contrast and or separately go get a PET CT with FDG, right? You just come in, you have one imaging appointment. It's a little longer than your standard appointment, but that's okay. It's one-stop shop for them. And so with respect to the FDG PET, we should just be doing it, in my opinion. So some future directions, where can we go with where we're at clinically now and progress it forward to help our patients and improve their lives? One of the things that we can consider is how we measure these patients now, measure the enhancing lesions for our patients. When there's solid masses like this, it's really easy to do, the sum product diameter metric that we talk about, where we just take bioorthogonal measurements and multiply them and get a sum product diameter. But when it's not a single focus, or when it's other than parenchymal with leptomeningeal disease, as we see here in the bottom panels, it really is that doesn't work so well. So, what is the role for autosegmentation, volumetric analysis, or subtraction analysis, like Rayno talks about sometimes? Current response criteria for primary CNS lymphoma do not integrate physiologic sequences, right? It's just mostly based off of T1 weighted postCAD images. So what is the role for CBV, FDG, and ADC metrics in that response criteria? And for that matter, non-enhancing disease, I think non-enhancing T2 signal change is becoming a more realized pathological process that happens and may suggest progressive disease despite the absence of enhancement. We talked about this. What is the role for staging of spine for patients that are asymptomatic? I think it's important given the incidence, but there's no formal recommendations that I'm aware of about that. And then finally, if being used, testicular ultrasound to rule out testicular disease in the setting of doing FDG PET CT, is that really needed? I don't particularly think so. I think the PET CT should be good enough, but using, talking about that ultrasound as an additional test in the future, I think could be helpful. So in summary, we have these physiologic PET and MRI metrics, which capture our biology and can stratify our outcomes for our patients. The IPCG group formally recommends specific ways of doing the MRI and the PET imaging, and I refer you to that paper because it's easily adoptable. Intentionally, we made it easily adoptable for everybody. And there's some limitations in our response criteria that I think can be improved upon by including some of these physiologic metrics and the way we do measurements. Thank you so much.
Thank you, Dr. Barajas. That was an amazing talk that took us through not just what's known, but what's also coming up. So, and I do have questions that we're going to save for our panel discussion. And with that, we're going to move on to our next speaker.
We could have all of the discussants that were able to stay on, turn their cameras on for this portion. That would be just great. Dr. Barajas, there was one question that had come in from my close colleague at MCW, Dr. Kathleen Shemenda. She thought a great deal of your talk, and she had a couple questions for you. What do you think about using percent signal recovery from the DSC curve, which has been shown to be a good way to distinguish primary CNS lymphoma from glioma? And then a second part to that question, given the recommended settings for PSR are different from DSC RCBB, she understands that some have been in a place for separate DSC protocol for that question. Do you have, or do you use a similar approach? Oh, you're muted, Dr. Barajas.
Sorry about that. Yeah,
No
this is a very complicated question from the imaging physics perspective, and I don't want to bore everybody who's not a geek like myself for imaging sciences to death. But needless to say, when you do that DSC sequence, I showed the kinetic curve. What I kind of didn't get into there in the tail of the curve, depending on, and what this is what that person's talking about, depending on where that in signal intensity ends up on the curve, relative to the baseline, you can measure the percent recovery of the curve, right? So that's just basically where is the tail of the curve with respect to the baseline. A lot of the papers that have been written on this subject were done using flip angles. So one of the parameters of DSC is that you have to put in a flip angle that are higher than what we recommend for CBV imaging. And that's because the higher the flip angle you have, the more T1 weighted the sequence becomes. So it captures the T1 effect of the gadolinium, which more so than the T2 star effect from the gadolinium. So you can capture all the signal properties from one sequence. So when since we've been doing DSC imaging, I started with Dr. Sumi Cha at UCSF. She really advocated for low flip angles, saying that, you know, if you want to measure T2 star, you should measure T2 star, right? And so we've always used, and I learned from her in clinical practice today, use low flip angles. And that's where the kind of the thought currently is in the imaging community, and what the recommendations are from the IPCG is to use lower flip angles in the 30 to 45 degree range. And so a lot of that data is skewed because it has been measured with the T1 effects. But to answer the question, yes, I really do like PSR as a metric, not only in differentiating different disease processes, because really what you're measuring there is the degree of contrast that's pooled in the interstitia, right? So the more contrast that's pooled in the interstitia, the higher that signal is going to go when you do it at the 60-degree flip angle. And it just means that it's more leaky. You can get there with other metrics like K-trans using a DCE sequence, which is also an optional sequence in the IPCG. But using the IPCG recommendations, you can still acquire the PSR. It's just going to be different from a lot of the published data. So I would really want to know, you know, what are the flip angle measurements using a 30 to 45 flip angle rather than, say, a 60 or a 75-degree flip angle. And absolutely anything that's helpful in, you know, differentiating different disease processes that otherwise look the same by gadolinium is incredibly helpful. And as our neurosurgical colleague pointed out, it alters the patient's management, right? I mean, he went from planning a totally open surgery to doing a stereotactic biopsy, and that has huge implications for our patients. So anything that can get there, I really like to see.
Wonderful, thank you.
I just have one more follow-up question on that line for you. You know, you mentioned now you are doing more PET MRI, so they're getting like MRI and then PET MRI, so they're not getting multiple. So is there any nuance to the gadolinium and FDG PET that are being, like, do they interact? Is there like a timing to that, or can you just do it parallel in sequence?
Great question, especially when you want to do the hybrid, you know, PET MRI concurrently. So, you know, when we do the FDG, we give it beforehand, right? So that we give the FDG Beforehand, the patient kind of hangs out for a little bit, and then we bring them into the scanner for the imaging. With the PET MRI, the PET MRI that we have, it acquires the signal simultaneously, right? So while you're doing your MRI sequences, say for whole body staging, right? You'll do whatever diagnostic sequences you feel is necessary for the whole body. It will simultaneously acquire the PET signal at the same time. So it's helpful for the patient because overall they don't have to go to multiple appointments, and then also can get everything done at once. The gadolinium doesn't affect the PET signal that I'm aware of. We use a MR-based attenuation correction factor. One of the things you have to do to get quantitative or semi-quantitative values for the FDG SUV measurement is you have to correct for the different soft tissue and bony structures that could be changing the amount of photons that are coming out of the patient and are being detected. We do that using an attenuation correction map. Classically, we did that with CT, a low-dose CT to measure the different densities of the tissues and correct for that. But now with the PET MRI, we have really good ways of doing that with an MRI sequence, right? So a patient doesn't have to go get a separate scan to do the attenuation correction map. And so the GAD, to my knowledge, wouldn't interfere with the uptake or distribution of the FDG. And then we usually do a non-contrast attenuation correction map, which you can give before you give contrast to do that.
Looks like we have another question in the chat. I can't read all of that though. So this was a question for Dr. Kramer. Let's say here. Yep.
Okay.
What other medical treatment options apart from steroids can be used for patients with suspected primary CNS lymphoma with symptomatic pressure effect awaiting surgery/biopsy for a definitive diagnosis?
So I'm actually not aware of any other specific medical treatments. I think if patients are presenting with elevated ICP and they have other sequelae from that, it does raise the question, what is the role of surgery for patients with significant mass effect? I don't think most surgeons in that situation would actually oftentimes operate quicker, even if it is if there is concern for lymphoma on the differential, just from the standpoint of relieving that mass effect. And then I guess back to the point of steroids, I think certainly we feel like steroids probably negatively impact the ability to perform the diagnosis, obtain the diagnosis, but at the same time, from a lot of these studies, you can see that oftentimes they end up getting steroids regardless, even despite that, we do get good tissue and can make the diagnosis. So if patients are presenting with symptoms, I would probably, at least from what I've gathered, I would probably go ahead and give them steroids, number one, and then if they have sequelae of elevated ICP and significant mass effects, that would also from a surgical standpoint lead us to probably operate, even if regardless of whether or not this is a lymphoma or not.
And I would just add to that, I would agree with Dr. Kramer. There's nothing as effective as steroids for chronically helping with the swelling. However, if someone's acutely sick, we have other measures like 3% mannitol. All of those can be used to acutely lower the ICP to buy some time getting to the OR. It all kind of depends on the extent of symptom and how acutely we would need to treat them. So we do have some medical options of treating higher ICPs that are like generic to all neurosurgical pathology that we sometimes use to stabilize patients. But as an alternative steroids per se, there's not much else in terms of medical management that we can do. And that leads me to a question for Dr. Nguyen is, steroids does affect, as we saw, the histology of it. Does it also affect the molecular profile? Like when you're showing all these various molecular subtypes, even if there are less live cells, if you did the molecular profiling on someone who was treated with steroids and without steroids, would that show an effect in that setting?
Yeah, that's a very good question, and it does affect the sensitivity of molecular testing of the cancer cells of primary CNS lymphoma. It really depends on the timing of the steroid therapy and versus when the biopsies are obtained. We have done studies looking at steroid-treated lymphoma cases to try to do molecular testing, and the preliminary experience that we have is that if it's within 7 days of steroid therapy, the testings are largely or non-conclusive, like very inconclusive or negative. And if we wait for like 2 weeks or like 3 weeks after steroid therapy, then the molecular testings become way more sensitive, kind of similar to pre-steroid therapy in terms of their sensitivity. But at the same time, in terms of tissue diagnosis, that's also true. If we wait for 3 weeks or longer, very often we can make a very definitive diagnosis of primary CNS lymphoma. So I think there's a correlation in the amount of tumor cells that are present to how likely molecular testing from the brain biopsy tissue can pick up molecular alterations.
Very good. I had a question for Dr. Correa, just with regard to the neurocognitive impact of seemingly all therapies that we utilize for primary CNS lymphoma. I think you made a great case that auto stem cell transplant clearly has less impact on cognition than those regimens that include whole brain. Now, granted, some of those whole brain regimens have utilized higher doses as well. And I think in the low dose era, we're waiting for the 11-14 data to kind of definitively say if that's effective. Some patients, even with stem cell transplant, do tend to recur, and whole brain still, I think, has a role perhaps at the time of recurrence. Has there been consideration to the utilization of cognitive protectors like memantine that have been utilized heavily now in the brain metastases realm, even looking at hippocampal avoidant approaches for delivering whole brain treatment?
I have not seen any studies attempting to use memantine, but I think it would be a good trial, to do that. At least as a pilot to do something like that. Regarding the sparing of the hippocampus for radiation therapy, I think that has been a little more controversial because of the infiltrative nature of the tumor, that there's some argument that, we shouldn't be, excluding any areas of the brain from treatment. But that is a bit, back and forth. I have not seen any studies of trying to do that in CNS lymphoma so far. But I think given, some of the results that we saw at least in our small study, but that we saw that after 3 years in patients who receive whole brain RT, they start declining in memory. So that would, argue for something like that, perhaps in a selected number of patients in which the tumor is very distant from that area. But I have not seen any centers planning on either one of those approaches, but I think those are very good suggestions.
Thank you.
Sure.
I have a follow-up question. Since kids do get this, and kids also get treated for it. Are there studies looking for like pediatric neurocognition versus adult neurocognition? And is there, like, if you follow pediatric patient long term, do they recover with possibly better brain plasticity, say, than an adult
Yeah.
60-year-old who is getting same treatments?
You mean the population of the adult survivors of childhood cancer? Is that
Correct.
literature? Well, I guess it depends a little on the population, right? Depends also on what kind of treatment they had. I think the most recent trials from a lot of these studies come from St. Jude's. They have hundreds of patients that they include in their research studies, and they have very, very interesting findings. I guess that I believe in, if I remember correctly, some of their studies show that the patients were treated early with radiation. They have worse outcome as well, but with less so with the chemotherapy only, like for leukemia, for example. But they do have sequela, long-term sequela from these treatments. I cannot talk more. I'm not as familiar with the pediatric literature to go in more details, but I followed some of the St. Jude studies, and they do find also, imaging changes, white matter changes long-term in these patients, with also then implications for achievement, academic achievement, and employment, and all of that. So I think the answer to your question is it probably depends on the age in which they receive these treatments. Apparently, when children receive these treatments before age 5, it is more deleterious than if they receive it later, and the kind of treatment they received. Yeah.
Thank you.
Sure.
Are there any other questions from the panelists or from our audience? It looks like Dr. Wen had a question. Perhaps Dr. Kramer, what is the role of peripheral blood in CSF analysis and diagnosis in the pre-steroid treatment setting?
So at least I can speak on behalf of our institutional practice. Although CSF sampling is kind of commonly discussed in book chapters and things like this, just given the fact that the yield is so low, we don't commonly do it. I think there are certainly occasions when there's a lot of diagnostic uncertainty around a new intracranial lesion where we'll perform CSF analysis and flow cytometry. But I think those are the situations in which we do it. For a new mass and a patient admitted to our service, it usually isn't something we commonly do, though. Although I think the promise of the liquid biopsy is that even with small samples, we can potentially find these mutations and identify the disease earlier. And I think I didn't talk about this too much, but the delay in diagnosis, I think, is a big problem. So if we can get a patient a lumbar puncture immediately upon admission, and also a lot of these patients are on blood thinners, and I think the safety of doing a lumbar puncture in that situation is much improved compared to doing a brain biopsy, whether it's stereotactic or open. So I think that the role for this is important. In the near future, I think that our job as surgeons will probably be much different than it is today.
Yeah, I agree with you, Mark. And I think Dr. Scherer actually this afternoon is going to take a deeper dive into that same topic as well. So great reason for everyone to stick around for the second part today. So it looks like we're about at time. I'll pause just for a bit to see if there are any other questions from the discussants or from the audience.
Yeah, I had a question for Dr. Kramer. I think in your talk, you hinted at the heterogeneity that can occur and I guess sampling error after biopsy, after steroids. I'm curious if you have used integrated diffusion weighted imaging into your biopsy, into the neuronavigational unit to help guide biopsies and, try to get that most cellular component of the lesion based on the ADC values.
Yeah, I think I was actually very interested to kind of learn about some of these things. The short answer is no, but we do have the capacity to do it with our navigation systems. It's actually fairly straightforward. All these sequences are immediately available on the machine. All you have to do is kind of you download these things and then you overlay them on top of each other, and you can very quickly scroll back and forth. And this could be super helpful when we're targeting. So I think it's something we should definitely look into.
Yeah, I'd love to help if that's something you'd like to collaborate on. Like you said, it's pretty straightforward. It's standard of care sequence. Should get integrated into the navigational unit, and it'd be interesting to see depending on your guys' lymphoma volume.
Absolutely.
Yeah, and I think that's the great part of like symposiums like this, to bring in these kind of collaborations, because clearly we can do better for our patients. And as Dr. Nguyen would agree, that the better the sample that we provide, the better, the diagnosis and molecular he can provide. I do have a question for you, Dr. Nguyen. It was really interesting to see how the naturally occurring has so many mutations versus the EBV just being there without any of the mutations. They're causing the same kind of pathology. So in the non-HIV group that's getting EBV, this like treating EBV effectively like cures the lymphoma for them?
Yeah, that's a very good thought. And I think from what we learned about PTLD, that are EBV positive in systemic cases, sometimes when you remove the immunosuppressants, a lot of times the PTLD can potentially improve or even regress. And similar story we have learned from H. pylori infections causing multiple lymphoma, right? Sometimes a eradication of the inciting organisms can potentially cure the so-called lymphoma. And I think in the world of EBV-driven DLBCL, diffuse large B-cell lymphoma, or EBV-driven PTLD, I think more have to be done to see whether that is the case. But it's very amazing, an oncogenic virus can hijack a lot of the cellular signaling pathways that kind of, recapitulate the disease process that require a lot of mutations in, non-virally infected individuals. I surmise that probably it may not be the case in diffuse large B-cell lymphoma, because I think the virus basically has already infected the individual, like probably a while back. And these patients, for some reason, have immunocompromised state, and then the EBV virus reactivate from the body, and then they somehow get immortalized and continue persistently, have activating signaling pathway that is stimulating these cells. And then these lymphoma cells often do harbor some certain mutations, even though, not as many as sporadic lymphoma that are independent of EBV. So I think it might be harder to treat these cases that are DLBCL. But, but the true answer to this is I'm not sure. I do think that these patients tend to get better prognosis because the number of mutations are a lot lower than sporadic lymphoma. I hope I answered your question.
So we are at time. I'd like to give everyone an opportunity to grab a cup of coffee and take a bio break if need be. We're gonna start back up again at 10:30 with the second half of our morning. Thank you so much to all of the discussants. These were just phenomenal presentations. thought-provoking. I learned a lot in everyone's talks. So thank you so much, and we hope to see you back for the second half.
Thank you so much.
Let me see. Yes, I do see Dr. Chukwueke back, and we'll start this late morning session. I just wanted to mention as part of the CME that Dr. Chukwueke will be discussing off-level drugs. However, she does not have any bias or conflict as part of the presentation. And I'm delighted to present her. This is Dr. Ogonma Chukwueke. She is joining us from Dana-Farber. She's a neuro-oncologist at the Center for Neuro-Oncology and Center for Central Nervous System Lymphoma at Dana-Farber Cancer Institute. She has both clinical and research interest in the treatment and innovative clinical trial for primary CNS lymphoma. And today she is going to update us on the management of relapsed and refractory disease. With that, please welcome.
Thank you, Mahua. I just want to make sure that everyone can see my slides, if it's visible to you.
Yeah.
Yeah. Excellent. So again, my name is Ugo Chukwueke. I'm a neuro-oncologist at the Dana-Farber. I work quite closely with Dr. Lakshmi Nayak, who many of you are likely familiar with seeing patients and conducting trials at the Center for CNS Lymphoma. So thank you again for inviting me to speak. And just for some housekeeping, you'll notice that Dr. Ferrari is also presenting updates. The two of us decided to split this up since it's such a big topic. So I'll present updates with respect to relapse refractory disease, and then he'll present upfront therapies in his talk later on this afternoon. So I have no financial obligations to disclose, and as Mahua mentioned, I will be discussing some off-label therapies. So in terms of the learning objectives, I just want to be able to outline sort of our current approaches to treatment of relapse and refractory disease, as well as define some of the evolving therapies for treating these patients. So I just wanted to introduce this section with what I hope is a representative case of the challenges as well as the opportunities that we have with managing these patients. So this is a patient of mine I've been following for probably the last 4 or 5 years now. He's a gentleman that presented to medical attention almost 4 years ago with his family noticing some mental status changes. He's ordinarily a very gregarious person, was speaking less and appeared somewhat flat to his family's report. He ultimately underwent MRI, which you can see here showing this homogeneously enhancing lesion involving the basal ganglia on the left frontal lobe, for which he underwent stereotactic biopsy. Pathology showed CNS involvement by DLBCL non-germinal center. As we do with all of our patients, his tumor underwent next-gen sequencing, and as you can see, it was PD-L1 positive. There was CDKN2A loss, and he was actually negative for MYD88 as well as CD79B, and negative for 9p24 amplification. The rest of his extent of disease evaluation was unremarkable, and so I treated him with high-dose-based methotrexate regimen with Temodar and rituximab. So I induced him with that regimen, and then he ultimately completed 2 additional doses of cytarabine for consolidation. In terms of his response to methotrexate, as you can see, over the course of the 4 cycles or 8 doses of methotrexate, you could see the really nice response, almost getting to a near CR by the time he was ready, by the time he finished consolidation with high-dose cytarabine. More recently, I have been following him in surveillance. He was doing quite well up into the end of last year, where he had a mechanical fall. Actually underwent workup locally for suspected cervical spine disease. However, you can see with this MRI brain, it showed new enhancement in the right frontal parietal lobe concerning for disease recurrence. I met with him again last month, and we have enrolled him on trial with rituximab, pembro, and ibrutinib for relapse refractory PCNSL. So for this audience, you guys are all aware about what PCNSL is, a poor prognosis variant of extranodal non-Hodgkin's lymphoma. This is a disease of older individuals. Median age of diagnosis is 65, with increasing incidence over the past decade in the elderly as well as in the immune competent. Our upfront therapy, with rare exception, generally includes high-dose methotrexate. And so while most people have nice responses to induction therapy, we know that the risk of recurrence remains high, usually about 50% within the first couple of years. Unfortunately, we don't have any standard of care recommendations for treatment of this disease, which remains an unmet need in our field. So this is part of what hopefully we can discuss in this talk today. And again, just to drive home the point that, this is work done by Dr. Houlier and the French LAC network, looking at all patients with PCNSL. There's a lot of work to be done for all patients. We do know that there are those who do well after treatment, but there's still the percentage of those who continue to have relapse disease. And then also specifically in the elderly, we do have to find better therapies for this population of patients. So this hasn't been for a lack of effort. So on this slide, I just want to illustrate some of the studies that have been completed looking at potential regimens, salvage regimens for recurrent relapse PCNSL. As I already noted, there aren't any standard of care consensus guidelines for relapse disease. I've highlighted two studies here, one by Dr. Susanne out of the LOC group, and then Dr. Casenda from the German group. And specifically looking at Dr. Susanne's study published in JCO in 2008. This looked at in patients with recurrent relapse disease, patients received CYVE, so cytarabine etoposide, in an attempt to still salvage them for consolidation with high-dose chemo and auto transplantation. Interestingly enough, the patients who were sent to transplant included patients with radiographic response to CYVE, as well as those who did not have a complete radiographic response to chemotherapy. Amongst all comers, overall survival was over 18 months, but specifically in the population of patients who underwent transplant, overall survival was close to 60 months. Similarly, in Dr. Casenda's study, patients were treated with rituximab, cytarabine, and thiotepa, followed by a thiotepa-based auto-transplantation. And again, median progression-free survival was over 12 months. And at the time of publication, median overall survival had not yet been reached. So this was interesting in terms of still suggesting a role for auto in patients that have not necessarily had a complete radiographic response to induction chemotherapy. So I wanted to just show, this is somewhat of a simplified view of how we tend to approach our patients with relapse disease. I imagine all of you also conceptualize this quite similarly. So following confirmation of relapse disease, we sort of, stratify our patients based on functional status, again, similar to probably what many of you guys in practice are doing. For patients with more favorable functional status, we tend to prioritize clinical trials if there is one that's available and one that seems to make sense. If there are no trials available, then we start thinking about off-label therapies. For patients who've responded nicely to methotrexate previously, we might consider a rechallenge of methotrexate or consider other therapies such as immunomodulatory drugs. In patients who are sicker and patients who we think may not be great clinical trial candidates, we still consider methotrexate rechallenge, but this is also where we think about palliative radiation and, if it makes sense, hospice, depending on how they're doing. So I'm going to take you through some of the newer therapies or some of the evolving therapies in terms of our approach to relapse refractory disease. In our group, and I imagine again more widely, BTK inhibition is being used quite frequently, typically through clinical trials or potentially as monotherapy outside of trial. There are two studies that I want to highlight that have looked at BTK inhibition as monotherapy. The first study led by Christian Groms out of MSK. At the time of the publication of this paper, this was a cohort, a phase 1 study, including both primary and secondary CNS lymphoma patients. They were treated at both 560 milligrams and 840 milligrams of ibrutinib, so the higher end of the doses for that drug. Overall response rate was over 70% for both the primary and the secondary CNS lymphoma cohort. Specifically for the PCNSL cohort, median overall survival at the time of this paper being published was about 15 months. In Dr. Sasan's trial, looking at primary CNS lymphoma as well as ocular lymphoma, primary vitreoretinal lymphoma, they were treated at the 560 milligram dose, also monotherapy. And there was overall response rates of greater than 50%. I think what was interesting specifically in Dr. Sasan's trial is that, you know, as we look back to Dr. Wen's presentation earlier today, thinking about MYD88 and CD79B, there were still responses in patients who were MYD88 negative. So perhaps still suggesting a role for BTK inhibition even in that population. And then there has also been work sort of considering BTK inhibition in combination with other agents, both by Dr. Groms and Dr. Leonakis. For Dr. Leonakis' study, BTK inhibition was combined as part of the DA-TEDR regimen, so including temozolomide, etoposide, doxorubicin, decadron, and rituximab. Overall response rates were greater than 70%, and as you can see, median PFS was greater than 15 months. In Dr. Grome's study, ibrutinib was combined with Ritux and methotrexate, and again, similarly, these were associated with both a clinical and radiographic response. One of the challenges, however, with the BTK inhibitors are the toxicities, which this crowd is certainly familiar with. So the benefit being clinical and radiographic response, the flip side being the toxicities, namely with respect to marrow toxicity and the risk for fungal infection. In the TEDR study, unsurprisingly, there were grade 4 toxicities with respect to marrow suppression, as well as invasive fungal infection. And across the board, there has been reports of higher rates of aspergillosis with the use of BTK inhibition. So this can, in some regards, limit our application of use of these drugs depending on the population of patients. So as I mentioned in that index slide, we also have used some of these immunomodulatory agents in our practice, lenalidomide specifically. And here are a couple of studies which have been done over the past few years, which have looked at the role of lenalidomide or pomalidomide in combination therapy for treatment of relapse refractory PCNSL. What I found interesting, and as you guys can see through this table, is that overall response rates, you know, hovering around 50 to 60%, median progression-free survival, also in the order of months. What has been associated with use of these drugs have been thromboembolic events. However, in each of these studies, the most common grade 3-4 toxicities or AEs were primarily hematologic toxicities. So perhaps suggesting still a role for these agents in the right patient population. So moving into the role of immune checkpoint inhibition in PCNSL, as with many other malignancies, we are starting to use immune checkpoint inhibitors more frequently, more recently in terms of in combination with clinical trial. Again, referring back to some of what Dr. Wen presented earlier this morning, we've really started to uncover some of the, within PCNSL, some of the presence of immune checkpoints in this disease, which makes the use of immune checkpoint inhibitors somewhat exciting and applicable, again, when we think about developing newer studies and newer regimens. More importantly, in our patient population, so the EBV negative PCNSL population, the majority of what we see, we've seen higher expression of both immune checkpoints and their accompanying ligands. So it's really allowing us to really explore how these drugs can be interlaced into novel treatment regimens for this population of patients. On this slide, I wanted to bring to your attention a couple of immunotherapy monotherapy studies which have been completed. So the first, and what this image is demonstrating is a patient who was treated on this phase 2 study of nivolumab in relapsed refractory PCNSL or primary testicular lymphoma, which is a completed study. And as you can see, looking at the baseline contrast enhanced head CT pre-treatment and over the course of treatment, I think the middle panel represents the scan after 2 months and the final panel as the scan after 13 months. You can see near resolution of the enhancing signal consistent with response to nivolumab. And then taking a lot of what we've learned over the last few years one step further, this is allowing us to look at the combinations of therapies, taking into consideration what we understand about BTK inhibitors as well as checkpoint inhibitors. There's 3 current clinical trials looking at the combination of BTK inhibitors with immune checkpoint inhibitors for relapsed refractory PCNSL. So hopefully everyone is still with me. I know I've gone through some of this quite quickly, but I know there'll be opportunity for questions later. So one of the newest areas of therapies that we're now investigating is the role of CAR T-cell therapy. And this has really been a natural evolution of use of this therapy, which we've seen used in systemic DLBCL. So there's a couple of published experience from different centers that I'd like to take you through some of the details of the work that's been done. The first of which was led by Dr. Fergal at Mass General, so just down the street from us. They looked at the Tisacel CAR T, so an anti-CD19 CAR T cell therapy. This was selected given the low rate of immune related neurotoxicity, as well as the early work that has looked at Tisacel in patients with secondary CNS lymphoma. So in Matt's cohort, 12 patients were enrolled. There were 6 patients who had complete responses to therapy, and only 1 patient who experienced a grade 3 neurotoxicity. As we sort of think about the clinical implications of this, we're also trying to understand the science better as well. And with each of these patients, we've had peripheral blood as well as CSF sampled at various time points. And what we've understood from this as well is that there's been accompanying expansion of CAR T cells in both the peripheral blood and in the CSF in 11 out of the 12 patients. And not unsurprisingly, there was more prominent CAR T cell expansion in patients who achieved a CR relative to patients who did not. So again, as I talk about the challenges and the opportunities with these therapies, with CAR T cell therapy, we know that while there is a lot of opportunity and potential benefit, there is also risk as it is somewhat of an intense treatment regimen. So as part of clinical trial, what we are following with our patients on the inpatient side are their neurotoxicity scores, and that's done by what's called the ICANN score. And so it's graded 1 through 4 based upon a couple of domains, one being the ICE score, which I'll show you on the following slide, as well as other factors, including their level of consciousness, presence of seizures, evidence of any motor dysfunction, as well as evidence of elevated ICP or cerebral edema. The ICE score is something that we do at the bedside and is done by our inpatient team with all patients who are admitted for CARS. And it takes into consideration orientation. So very simple bedside assessment, naming, the patient's ability to follow commands, their ability to write, and their level of attention. So as I mentioned before, this is what's taken into consideration when coming up with the ICANN's grading. So there's also been updates with respect to the CAR-T experience with the French LOC network. They published their experience with both Tisocel and Axicel and relapsed refractory PCNSL. Thus far, they've had a total of 9 patients treated, and they have some survival data, specifically the PFS rate at 12 months, which is 22%, as well as median overall survival thus far is 17 months. And more recently, they presented their data at ASH last year, Dr. Hulier. So again, this is an update to their CAR-T experience using their LOC network database. What I found interesting about this set of data is that I think it reflects more of a real world experience, median age being 68. These are patients who have been heavily pretreated with multiple prior lines of therapy. These are patients who've also undergone prior auto. In terms of the breakdown of the selection of the specific CAR, both of these are anti-CD19. So Axicel, 5 patients treated with Axicel and 14 patients treated with Tisocel. Again, reflecting the aggressive nature of this therapy, there were 21% of their patients who did have higher grades of neurotoxicity, as well as higher grades of cytokine release syndrome. And then lastly, just to present our experience at Dana-Farber, this was presented by both Dr. Nayak and Dr. Karen Jacobson, who's our colleague in the systemic lymphoma group here at Dana-Farber. So in our study, our pilot study of Axicel, we included both patients with relapsed refractory PCNSL, as well as patients with CNS relapse of their known systemic DLBCL. So of the 9 patients who were treated so far, 6 of them have had relapsed refractory PCNSL, with the median number of prior treatments being 2. What we've done with this study is that once the patient has completed screening, we have not allowed any additional therapy. So some patients have had some bridging therapy done prior to screening, including focal radiation or single doses of methotrexate, just to bridge them to receipt of their therapy. With respect to safety, we noticed 3 grade 3 ICANS in our cohort. There were no grade 3 cytokine release syndromes, and like I said, a total of grade 3 ICANS with 4 total ICANS noted in this population. And this study is still ongoing as of now. So I'm going to take it back to my patient. So what's happening with him? So as I showed you, the scan from last month, which showed recurrence of disease, this new right frontal disease, and a scan that actually was done earlier this week, you guys can see that he's had pretty significant response and decrease in enhancement just after 4 weeks on therapy, demonstrating a nice early response to his on trial. What I do want to emphasize is that this has not been without cost. Unfortunately, about 2 weeks into trial, he was admitted for fever, functional decline. He was found to have a bacterial pneumonia. as well as found to have new skin changes characterized as a bullous dermatitis, which was subsequently biopsied and found to be consistent with pembrolizumab, with the Keytruda, so immune checkpoint inhibitor mediated cutaneous infection. I think this really highlights, again, some of the challenges and opportunities with the immunotherapies and with the newer therapies writ large. With the immune-related adverse effects, oftentimes these patients may require steroids, which can interfere with the efficacy of immune checkpoint inhibition. And as I demonstrated in the earlier study of nivolumab monotherapy, sometimes we do see delayed responses. However, during that time, there is a worry and risk for further neurologic deterioration. On the flip side of that, as we think about BTK inhibitors, we know that there's the benefit and the potential for a more rapid response. However, there's also the risk of a lack of durability of that response, which can contribute to shorter progression-free survival. As with any of our therapies in this space and in treatment of patients with primary brain tumors, there's always the concern for CNS and tumor penetration of drug. And all of this really highlights the need for more effective treatment combinations. And again, a lot of this is work that is underway. And I just wanted to, there's a lot of people who are behind all of this work. Most importantly, I would like to thank our patients and our families who participate in studies and who are very generous with their time and resources. And with that, thank you.
That was really a wonderful talk and amazing synopsis of all the work that's being done in relapsed and refractory primary CNS lymphoma. Thank you so much. I look forward to hearing the addition of Dr. Ferrar's talk as well. And I certainly have some questions for you, but as we had done in the morning session, we'll hold those for the panel discussion. So thank you so much. That was just great. I'm very excited to introduce next Dr. Chelsea Penix from MD Anderson. She has been down there since 2012. Her clinical and research interests lie in improving the outcomes of patients with multiple lymphomas. Dr. Penix's ultimate aspiration is to advance the clinical outcomes of patients afflicted with Hodgkin's and non-Hodgkin's disease via the minimalization of normal tissue toxicity due to radiotherapy. So very excited to hear her discuss the role of radiotherapy in primary CNS lymphoma.
Can you hear me okay?
We sure can. Thank you so much.
No problem. And are my slides visible in the right mode?
Yep, we can see them. Thank you.
All right. Checked 2 boxes. And now the fact that I'm speaking and not muted is a good sign. So let's get started. Good morning, everybody. Thank you for the opportunity to join you today. I really appreciate the inclusion of radiation therapy in this symposium. I know historically, and we have a lot of concerns about toxicity. And I want to kind of go through where those concerns have come from and how we've evolved in regards to the utilization of radiation therapy in this disease. These are my disclosures and our learning objectives. So let's start off with a case for a 70-year-old woman who presented with some neurologic symptoms. A workup that included MRI revealed a lesion in the right frontal cortex with some flare abnormality, and she had a biopsy that revealed a non-GCB diffuse large B-cell lymphoma consistent with primary CNS lymphoma. I'm not going to belabor this for this audience. This is a little bit of background and presentation of patients with primary CNS lymphoma, typically impacting older adults. And you can see the typical MRI findings on a classic type lesion. This is a single mass infiltrating the corpus callosum that is enhancing homogeneously with contrast in that T1C. And you can see some minimal to moderate flare abnormalities in these lesions, and they can be multifocal, often or periventricular. One thing that I do want to mention in terms of workup are 2 things that we want to stress, which is 1, to make sure that we do a proper ophthalmologic evaluation with an ophthalmologist, even in the absence of patients reporting symptoms. And this is not something, as you guys know, that can be detected on MRI of the orbits. It's vitreal involvement within the vitreal fluid, so really requires a clinical evaluation and potentially vitrectomy because they can have concurrent ocular involvement. And also want to mention that CNS disease can be part of a systemic disease process and not just primary CNS lymphoma. And I'm going to highlight that in this next slide with the case that I recently saw this week. And this is a gentleman that presented with left-sided weakness. He has these profound abnormalities you can see in the brain, or biopsied and found to be diffuse large B-cell lymphoma. But in terms of the PET workup, you can see here on the scalp, there's an abnormality uptake here in the testicles. And on the PET CT scan, the radiologist noted some abnormality and avidity that was increased in the bilateral testicles, confirmed on ultrasound. And so just have to remember that this can also present as a secondary site of involvement. Okay, so evolution of the management for the role of radiation. High-dose radiation was used in the past, many, many decades ago, and it's very intriguing that despite very high doses of radiation, I'll go into it in a little bit, outcomes were not great, roughly 12 months median survival. Borrowing from this assesses with adriamycin-based chemotherapy for systemic diffuse large B-cell lymphoma, the thought was that CHOP-like regimens followed by high-dose radiation might improve outcomes. That was found not to be the case, and most surmise that because of the poor penetration of these drugs into the central nervous system. Ultimately, the game changer was the utilization of high-dose methotrexate, largely pioneered by Lisa DeAngelis and colleagues at Sloan Kettering. But still incorporating high-dose radiation therapy into those regimens. I'm going to show you the downside of that approach. And then where do we stand now? We're hearing a lot about the exciting advances, including immunobased therapies. But I'm going to talk a little bit about traditional consolidative approaches that would potentially include reduced dose whole brain radiation. So to review a little bit of the history and why all of the concerns regarding radiation toxicity in this disease, I just want to show you that this is what was used in the past, radiation alone to the whole brain, a large dose of 50 gray with a boost to the tumor bed to 20 gray. And these were not using CT-based simulation strategies or heterogeneity corrections, and not even using high-dose energy photons, but using cobalt-60. So these plans back then were very hot. And despite that, you have a median survival of 12 months. And despite that high dose, one thing that's very interesting, if you go back to these historic studies, is that the main pattern of failure is in the brain. So 60 gray boost and 25 out of the 28 relapses occurred locally within the brain. So ineffective radiation therapy alone, despite very high doses. And so this was, as we all know, the game changer, the inclusion of high-dose methotrexate that's penetrating the central nervous system and having high activity against this disease. And with that incorporated, radiation was still utilized, but still to a high dose, and I'll show you about regarding the radiation details in a moment. And so there was a lot of excitement regarding this, but with longer follow-up after 45 gray given after a high-dose methotrexate regimen with ARC consolidation, toxicity was noted. And so this is the standard regimen that was reported out of Sloan Kettering using 3.5 grams per meter squared of methotrexate-based chemotherapy with 45 gray to the whole brain and consolidation with high-dose ARC. Improving outcomes and very encouraging. But wait, with long-term survival and continued follow-up, there's a lot of concern regarding neurotoxicity. I'm going to describe that in a bit. But I do just want to mention that in this study, when they looked at the survivors describing the radiation that was given, most patients were given still 40 gray with a 14 gray boost, so greater than 50 gray to the brain. Some had 50 gray whole brain, and some had 40 gray whole brain. And so these are doses that were used historically, but doses that we wouldn't use today, and I'll show you why. So as we know, with longer follow-up, especially for patients over the age of 60, we have this progressive leukoencephalopathy. And this is not a patient has some short-term memory loss or they forget where they put their keys, or they're not as good as multitasking as well, or they just have some slight abnormalities in neurocognitive battery testing. No, this was profound, pretty terrifying toxicity, characterized by white matter changes on MRI, profound dementia, gait ataxia, patients became incontinent of urine, and they describe in this study that many of them required custodial care. And in many cases, the neurotoxicity was life-threatening. And you can see in the figure depicted on the left, the proportion of patients that develop neurotoxicity is much more significant for those greater than the age of 60. So what can we do to reduce toxicity, but while escalating treatment somewhat, because we're aiming for long-term disease control? And so one approach after RMPV or methotrexate-based chemotherapy is reduced dose whole brain radiation therapy. Another approach, which has been touched on and will be touched on more today, is high-dose chemotherapy and autologous stem cell rescue. So this is a long-term follow-up of really encouraging study that came out of Sloan Kettering. Their initial publication was in 2007, and these are their long-term outcomes that they report of a phase 2 study of RMPV, followed by reduced dose whole brain, 23.4 gray, 1.8 gray fractions for patients that experienced a CR to induction chemotherapy. And with this, in this study, they received 5 to 7 cycles of RMPV. If they had a CR after 5 cycles, they were candidates for whole brain radiation. And if they did not achieve a CR, they received 2 more cycles. If they had a PR, they still got 45 gray. And so we'll talk about that in one moment. But with the reduced dose whole brain strategy, and there was extensive neurocognitive testing in this study, the median PFS was 7.7 years with a 2-year PFS of 77% and median overall survival not reached. This was at a median follow-up for survivors of over 6 years, roughly 6 years. And so they conclude that whole brain radiation 23.4 reduced dose after CR chemotherapy has good outcomes, minimal neurotoxicity. This has been evaluated in a cooperative group setting with NRG and RTOG, looking at the same chemotherapy regimen and then randomizing patients to reduced dose whole brain 23.4 versus no further treatment. And with their primary endpoint of intent to treat PFS, they found that PFS was improved in those patients that received combined modality therapy. They did not appreciate moderate to severe neurotoxicity that was increased in the combined modality arm, but of course we do need longer follow-up to confirm these equivalent neurocognitive outcomes. So back to our case of the patient that presented with that disease that you can see here. The patient received 5 cycles of RMPV. It was not deemed to be a good candidate for high-dose chemo autologous stem cell rescue, and so therefore was referred to us for consideration of reduced dose whole brain after a CR to therapy. And so this is our simulation technique. Patients are supine on the table. There's a mask that we make for them. This is your standard whole brain field going down to the base of C2, including the posterior half of the globes. And we use something called field and field to reduce hotspots to make sure that the dose is as homogeneous as we can get it. I'm going to show you. It's always nice as radiation oncologists, we like to include pictures and videos. So this is showing you the field and field approach that we utilize for delivering the whole brain. We also, in all of our patients, we extrapolate from the utilization of memantine, which is an NMDA receptor antagonist, in an effort to ameliorate neurotoxicity in these patients. And this is really leveraged from a randomized trial among patients that had solid tumors that were receiving whole brain radiation therapy. They're randomized to control placebo or memantine. And memantine really was associated with improved neurocognitive outcomes, as you can see there on the slide. And so for our patients, despite the fact that this study was for solid tumors, we utilize this approach for all of our patients that are receiving radiation to the brain. We prescribe memantine. And so in thinking about the approach that's best, high-dose chemotherapy and autologous stem cell rescue versus whole brain, that was a topic of investigation in the second arm of this ILSG 32 study. And the first randomization I'm not going to review, but in the second randomization, they were comparing whole brain radiation therapy versus high-dose chemotherapy and transplant. Unfortunately, it would be lovely if this study used a reduced dose whole brain of 23.4 gray, because truly dose does matter in this disease in terms of contributing to toxicity. There is some synergistic impact on neurocognitive toxicity of methotrexate and radiation. And we do find that when the dose is lower, that the risk of neurotoxicity is lower. So it would be nice to have 23.4 gray in this study, but nonetheless, it was 36 gray with a 9 gray boost for partial responders. And what they found was no significant difference in 2-year PFS by intent to treat analysis or per protocol analysis. I will note there were deaths, early deaths in the autologous stem cell transplant group due to toxicity. And we would expect for radiation, we wouldn't expect to see early deaths, and the toxicity, we'd have to do longer follow-up. But in their neurocognitive comparison, they did find some significant improvement in attention and executive functions for patients that receive high-dose chemotherapies compared to whole brain radiation. However, they didn't note that severe, terrifying neurotoxicity that we described earlier of patients that received 45 gray and higher doses after methotrexate. So back to our patient. This is a different patient. This is a 69-year-old woman that had primary CNS lymphoma after 5 cycles of RMPV. Unfortunately, there was persistent contrast-enhancing disease after 5 cycles, but the patient was found to tolerate RMPV poorly. And so what options do we have here for those that do not experience a complete response to treatment? Well, we can do something called a boost. And this is something that we evaluated in a retrospective series that we published, our group here at MD Anderson. We were looking at patients that had residual disease that they responded, but they had residual disease after methotrexate-based chemotherapy. And instead of giving them 45 gray to the whole brain, which is the approach in the Sloan Kettering study that I described, we instead de-escalated the whole brain to 23.4 gray, but then administered a boost to a higher dose to the site of residual disease to get that dose closer to 40 to 45 gray. And what we found with this approach is that de-escalating the whole brain dose via this boost approach did not appear to compromise the efficacy of radiation for patients that had a partial response to methotrexate-based chemotherapy. And so that's what we did for this patient. The patient was treated with 23.4 gray to the whole brain and the posterior globes, and then we did a sequential boost to get the total tumor dose close to 40 gray. And the patient's doing well more than 6 years after therapy. There's controversy in terms of the boost contouring approaches. Obviously, you definitely want to incorporate the area of persistent enhancement because that represents gross disease. But often we do also include the initial contrast enhancing disease, and there's more controversy in whether the flare should be treated. And that's largely guided by the extensiveness of the flare. I find if the patient has a really extensive flare abnormality, such that me including that in the boost would end up almost being whole brain, then often I'll just cover the contrast enhancing disease at the time of treatment and at diagnosis if that's feasible. So to conclude, I would say that reduced dose whole brain 23.4 gray is a good consolidative treatment option after RMPV. We typically do recommend for our younger, fitter patients that are candidates for high-dose chemotherapy and autologous stem cell rescue to pursue that therapy, as it may provide superior preservation of their neurocognitive function. However, patients that have a partial response and aren't candidates for other therapy, reduced dose radiation with a boost to their persistent disease is an encouraging treatment option for these patients. So I know many of you have been on this webinar for a couple hours now. We've got a few more hours to go. I want to thank you for your attention, and hopefully the rest of the day you are embracing the alertness of my youngest child, Madison, in the back seat, as opposed to my youngest daughter and my son here, as you can see, who are knocked out. Thanks for your attention.
All right, I love that last slide, Dr. Penix. Thank you so much for sharing that, and thank you so much for walking us through kind of the bit of the history with regard to whole brain. And the changes that are happening with regard to reduced dose. I think there's exciting opportunities there. Again, we'll save questions to the end, but thank you so much for that wonderful talk. We appreciate you. Next, I'd like to introduce and am absolutely honored to introduce Dr. Ferrari, who has joined us today. He is actually going to be delivering his talk will be delivered via a pre-recorded segment. He is actually hosting a European primary CNS lymphoma conference today as well, and we were happy to steal him away for the second half of our talk. So he is absolutely an indisputable authority in brain lymphoma, and he has defined the treatment guidelines that have been applied worldwide in treatment of this disease process. He's the founder of the International Extranodal Lymphoma Study Group and the Italian Lymphoma Foundation. He's a member of numerous international scientific societies and is on faculty at the European School of Oncology. Today, he's going to be discussing with us updates in the first-line management of primary CNS lymphoma. Dr. Ferrari, thank you so much for joining us.
Good morning, everybody. Let me thanks to the organizer for inviting me to this important journey on primary CNS lymphomas. They asked me to discuss about some updates in first-line treatment of this very aggressive malignancy. These are my disclosures. And after my presentation, the learning will be able to indicate first-line treatment to patients with primary CNS lymphoma, stratify patients for treatment in 3 different subgroups, fit, unfit, and frail patients, and to design standard of care for these 3 therapeutic subgroups. So the primary CNS lymphoma shows important management difficulties. In particular, which is the median age at diagnosis is between 60 and 65 years, with a higher incidence in the last 10 years in the elderly populations. Then a high proportion of PCNSL patients are older than 65, 70 years. And they exhibit a poor performance status at presentation. Sometimes the biopsy is not performed at all, and many patients are addressed to receive palliative treatment. Moreover, a consensus on the best strategy is lacking, and even if there are some international groups that are working to put together the general guidelines, there are some geographical differences in the use, for example, of the best chemotherapy combinations and others. Moreover, a few reference centers exist, and patients often cannot be referred to other centers due to the neurological impairment and poor performance status. And this is the result, that a very devastating disease in the brain with obviously progressive symptoms, and the survival curve, which is the poorest among all diffuse large B-cell lymphoma of extranodal organs. The overall therapeutic strategy includes 5 different steps: the early diagnosis, to complete pretreatment measures, to complete the staging workup, to perform an accurate patient stratifications, and then to choose the best induction and consolidation for this patient, which in my opinion should be supported by the previously published trials as models for the therapeutic choice, and should not be kept to individual choices. This is the best way to offer to our patients an already tested treatment, both from the point of view of the safety and the efficacy. An important dilemma in the treatment of primary CNS lymphoma is the choice between strategies designed to intensify the therapy and to improve the cure rate, and treatment de-escalation strategies to avoid neurotoxicity. Every drug, every strategy that will achieve effective levels or concentrations in the CNS tissues will be followed by some degree of neurotoxicity. Then it is important to think about which are the best combinations in terms both of efficacy and neurotoxicity. The patient stratification should not be based on age as exclusive parameter. Usually the patients up to 65 years old and there are well documented guidelines for this group of patients. Similarly, we know that patients treated with palliative purposes that are older than 80 years old. But in the middle, there is very often we use personalized treatments, in particular between 65 and 75 years old, because the comorbidity, the clinical conditions are extremely heterogeneous in this subgroup of patients. But we use many other parameters to define the best treatment. The performance status, which is an important prognostic factor, the organ function, the comorbidities, frailty, the risk of neurotoxicity, in particular in patients with other neurological disorders or patients with different vascular disorders, and obviously the prognostic score. We use two different prognostic scores around the world, the ELG, which is based on age, performance status, LDH, serum level, CSF protein concentration, and the involvement of deep areas of the brain, and the Memorial Sloan Kettering Cancer Center score that includes only age and performance status. So on the basis of these parameters, the decision is between fit patients, that is, patients that are suitable candidates for chemotherapy, or patients, unfit patients, which are unsuitable for chemotherapy. For fit patients, the first choice is to offer them the clinical trial registration, according obviously to the availability and the eligibility of these patients. In the case of unfit patients unsuitable for chemotherapy, whole brain radiation therapy alone or the use of single drugs that were recently reported in important prospective trials can be considered. There is a part of the patients, particularly frail patients, that where the improvement of the neurological symptoms and quality of life is hard. In this subgroup of patients, sometimes we have to offer the best supportive care. So for patients who are feasible for chemotherapy, but are not candidates for prospective trials, we can distinguish two different groups: the fit patients suitable for autologous stem cell transplant, and fit patients unsuitable for this treatment. For the first group, we use intensified chemoimmuno combinations that usually include methotrexate delivered at high dose with an alkylator, and with or without rituximab, and with or without high-dose cytarabine. There are different combinations used in different countries, and it is important that the centers use the combinations that are more friendly or that they know better. What about the schedule of methotrexate and the dose of methotrexate? We have to remember that methotrexate has a triphasic plasmatic clearance, then it should be delivered in an initial bolus, fast bolus, that allow to reach alpha level concentrations very fast. And this will be followed by a more prolonged exposure to this drug. And we have to remember that this drug is able to penetrate the blood-brain barrier only when it is administered at high doses. In particular, when we use a short infusion of 3 hours, or at least shorter than 6 hours. And when we use a dose of at least 3 grams per meter square. In fact, doses of 1 gram per meter square or more achieve tumoricidal levels in the brain. Doses of 3 grams per meter square or more produce tumoricidal levels in the cerebrospinal fluid. Conversely, prolonged infusion, 24-hour infusion, is not associated with tumoricidal levels in the CSF, and then we prefer to don't use this strategy to deliver methotrexate. Overall, regarding the tolerability, 45% of the patients treated with 8 grams per meter square of methotrexate needed for dose reduction in the published trials, mostly due to nephrotoxicity, but also due to other reasons. And then we believe that 3.5 grams per meter square is a good compromise between safety and toxicity. So some groups around the world published the single arms phase 2 trials addressing combination of methotrexate, an alkylating agent, and rituximab, and sometimes with excellent results. And the most commonly used alkylating agents were procarbazine and temozolomide. However, per design, none of these trials was able to confirm the contribution of the alkylating agent and the rituximab in this setting. The only randomized trial focused on this aim was the ELG32 trial. In this trial, patients up to 65 years old with a performance status up to 3, or up to 70 years old with a performance status up to 2, were randomly allocated among the conventional methotrexate cytarabine arm, or the same chemotherapy plus 2 doses of rituximab, or the same chemoimmunotherapy plus tiotepa. Patients received 4 courses of this treatment. The autologous stem cells were collected after the 2nd course, and according to the response after the 4th course, patients with at least stable disease were randomly allocated between whole brain radiation therapy or carmustine tiotepa conditioned autologous transplant as experimental arm. And these were the results for the induction matrix, that is the combination of the 4 drugs, was associated with a significantly improved progression-free survival. And for the first time in a PCNSL prospective trial, we were able to demonstrate a significant improvement in overall survival with the use of this combination after a median follow-up of 88 months. Interestingly, with a longer follow-up, we confirmed also a role of the addition of rituximab in comparison with chemotherapy alone, with a significant improvement in overall survival. Then, for the fit patients suitable for autologous transplant, for patients who achieve a response to induction chemotherapy, we offer these patients a consolidation. There are two main strategies that are confirmed by in large clinical trials. The age-tailored autologous stem cell transplantation and the whole brain radiation therapy. These two consolidation strategies were compared in two large randomized trials. In the ELG-32 trial, there was not a difference between radiation therapy and autologous transplant after a median follow-up of 88 months, both in terms of progression-free survival and overall survival. The only difference among these two consolidation strategy was neurotoxicity, which was significantly higher in patients treated with radiation therapy, in particular in terms of attention, memory, and speed. When the patient achieves a good response to matrix, a partial or complete response, and receive a consolidation, either radiation therapy or autologous stem cell transplant, the results are outstanding, with a 7-year progression-free survival close to 70% and an 8 years overall survival of 70%, and without a difference between these two treatments. Similar results were achieved by the French group on the PRECISE trial, were recently published the updated results showing an advantage in progression-free survival in the patient treated with autologous transplant in the per protocol population. And in the same way, with a higher neurotoxicity in the patient who receive radiation therapy. What happens when we wish to de-escalate the intensity of the treatment? Because some patients are not good candidates for autologous stem cell transplantation. This was the main endpoint, the main objective of two large randomized trials. The first one was the Alliance trial, that where the patients were treated with a combination of rituximab, temozolomide, and methotrexate, and at the end of 5 courses of treatment, the patients were randomly allocated between a myeloablative treatment with carmustine, tiotepa, conditioned autologous transplant, and or with a non-myeloablative chemotherapy with an infusion of high doses of cytarabine and etoposide. And these are the results of the primary endpoint, the progression-free survival. As you can see, there was a significantly improved progression-free survival in patients treated with autologous stem cell transplant. Hopefully, in this trial, we expected to see a better tolerability among the patients treated with non-myeloablative chemotherapy. And unfortunately, the tolerability was very similar in both arms. Then the autologous stem cell transplant remained the best choice as consolidation for young patients. With a similar design in Europe, we investigated the role of non-myeloablative chemoimmunotherapy in the ELG-43 randomized trial. In this trial, the patient received, the patients were registered following the same selection criteria than the ELG-32 trial. The patient received 4 courses of matrix, and then patients with complete or partial response were randomly allocated between high-dose chemotherapy supported by autologous transplant or conventional dose consolidation with a high-dose ifosfamide-based combination called the VIC. 368 patients were enrolled and 230 patients receive autologous transplant. Were referred to the randomization. There was a treatment-related mortality lower than 4%, which is a very important data. There was not unexpected toxicity. Obviously, infections and febrile neutropenia or an oral mucositis were significantly more common in the autologous stem cell transplantation arm, with treatment-related deaths on 3.4% in the transplantation arm, 0% in the VIC arm, and there were no difference in neurotoxicity between these two arms. Both treatments were active, with a complete remission rate at the end of the whole program of close to 65%, but there was a significantly difference in progression-free survival and overall survival in favor of autologous stem cell transplantation that remained the standard of care for patients under 70 years old. For fit patients unsuitable for autologous stem cell transplantation, we use similar combinations, but less intensified, like those tested in two important trials. The first one was a French trial focused on patients aged 60 years or more, where two combinations, MPVA and methotrexate temozolomide, were compared. This trial was performed before rituximab era, and we have to take into account these results with the doubt of a potential additional event of this monoclonal antibody. Anyway, tolerability was good for both arms, with very similar rates in terms of grade 3/4 toxicity, toxic death, and methotrexate dose reductions. The MPVA regimen seems to be more active, but it did not achieve the significant levels. And there were similar progression-free survival and overall survival with these two chemotherapy regimens. Another important trial in the patients older than 65 years was the PREMAIN trial that enrolled 107 patients treated with rituximab, methotrexate, and two alkylating agents, lomustine and procarbazine, followed by a 6-month maintenance of procarbazine. After a safety interim analysis, lomustine was excluded from this combination. And this was due to the fact that with a similar activity and similar efficacy in terms of progression-free survival, the addition of two alkylating agents was associated with a significantly higher toxicity in terms of hematological toxicity and infections. Then this trial demonstrates that a combination of methotrexate, a single alkylating agent, and rituximab is effective also in the group of old patients. At the last ASH meeting, the German group presented the initial results of the MARTA trial. The MARTA trial is a trial focused on patients aged over 65 years, treated with autologous stem cell transplantation. This is a single-arm phase 2 trial where the patient received combination of rituximab, methotrexate, cytarabine for 2 courses, and those with at least stable disease were referred to consolidation with rituximab, busulfan, tiotepa. 2/3 or more of these patients were older than 75 years, with a similar characteristic with respect to others, patients with primary CNS lymphomas. 71% of the enrolled patients receive autologous stem cell transplantation. And these are the results. There were, in terms of efficacy, obviously most of the patients experienced hematological toxicity, with more than 60% of febrile neutropenia, grade 3 or more, in after consolidation. And the mortality was 3.7% after induction and 2.7% after consolidation. Anyway, we can conclude that it was tolerated very well in a high-risk group of elderly patients. The response rate at the end of autologous transplant was almost 90%, with a 64% complete remission rate. And at a median follow-up of almost 2 years, the progression-free survival was 58%, and the overall survival was 60%. That is a good result in a selected group of elderly patients. Then we can consider also for elderly patients other strategies. In particular, the complete remission was achieved of wait and watch, whole brain radiation therapy at low doses, or maintenance. The maintenance with 1 year of temozolomide was assessed in the trial of the Nordic lymphoma group. They used an intensified high-dose methotrexate-based polychemotherapy, and then patients older than 65 years continued treatment with maintenance temozolomide, and the survival curves were very similar in the two age subgroups, suggesting a positive effect of maintenance temozolomide. Unfortunately, this year, the Japanese colleague published the initial results of the randomized trial when they compared the role of temozolomide as radiomimetic with Wolverine and as adjuvant treatment with Wolverine radiation therapy. After registration, the patient received 3 courses of high-dose methotrexate alone, and then were randomly allocated to receive Wolverine irradiation at different doses according to the response to methotrexate, or Wolverine radiation therapy plus temozolomide as radiomimetic and then as adjuvant treatment. Unfortunately, this strategy was not associated with positive results. There was not an improvement in progression-free survival and overall survival. Anyway, I believe that high-dose methotrexate alone is not a suitable treatment as induction for this very aggressive tumor, and then it would be nice to investigate the role of temozolomide maintenance when a more intensified induction chemotherapy is used. Lenalidomide is a drug with an immunomodulator activity that showed some activity in some retrospective and prospective trials in primary and secondary CNS lymphomas. One of the roles for this drug may be as maintenance after an induction, after a response, for example, to a salvage treatment. This was demonstrated by a study by James Ravenstein at San Francisco, showing sometimes very encouraging response durations with the use of lenalidomide maintenance after different salvage treatments in this small group of patients. Then we are exploring the role of lenalidomide maintenance in elderly patients with primary CNS lymphoma in the Fiorella trial. All patients older than 69 years old are registered, and patients eligible for therapy but not eligible for autologous transplant are included in two different parts of the trial. The part A, which includes patients eligible for high-dose methotrexate. In this, the patients receive 2 courses of the rituximab methotrexate procarbazine combination, and after response assessment, the patient are randomly allocated between 2 different arms, procarbazine for 6 months as control arm, or lenalidomide for 2 years as experimental arm. Patients not eligible for high-dose methotrexate are treated with Wolverine irradiation plus temozolomide and rituximab with a single year of temozolomide treatment. Patients not eligible for any treatment are registered in the trial to collect clinical data in order to better estimate potential selection bias in this trial. And the last focuses on an uncommon entity, the primary vitreoretinal lymphoma, that is the lymphoma which is limited to the eyes, infiltrating the vitreous and or the retina. It affects 20% of patients with primary CNS lymphomas, usually with bilateral disease and preceding brain lesions in a high proportion of patients. These patients usually complain floaters and blurred visions and generate some difficulties in diagnosis and response definition. In the last years, the use of genetic markers, in particular MYD88 mutations, and the level of interleukin-10 without the vitreous and the aqueous humors can be used to favor diagnosis and to monitor the disease. And these are the strategies we suggest for these patients. In patients with good general conditions, and good renal functions, the treatment should be the same used for other patients with primary CNS lymphoma. That is a high-dose methotrexate-based chemotherapy. In the patient who achieve a complete remission or a partial response, consolidation with ocular irradiation is suggested. And we are now investigating the role in some of these patients of autologous stem cell transplantation. For the patient with progressive disease or who did not achieve a response or experience a relapse, for fit patients, we use a similar strategy than used for our other primary CNS lymphomas, that is chemoimmunotherapy followed by tiotepa-based autologous transplant. For unfit patients, the radiation therapy or the use of intravitreal drug injections with methotrexate or rituximab, or single drugs or ocular irradiation are suggested. For patients in poor general conditions, the treatment with oral drugs or with intraocular injections or best supportive care as are suggested. So in 2023, the next steps to improve these results, the therapeutic outcome in first-line treatment, are mostly focused to improve the diagnosis, because an early diagnosis is the best strategy for a more effective treatment. And using tumor cell-free DNA biomarkers, and with progress in neuroimaging, in particular, the IPCG consensus that was recently published in neuro-oncology. The development of new therapies like targetable molecules and pathways and adaptive cell therapy, or the use of blood-brain barrier permeabilization, and obviously focusing in particular on elderly patients, because it's this is the subgroup of patients that need for a higher improvement in survival, mostly with the identification of new drugs and new strategies with, for example, the use of animal models. And I wish to thank all of us for your kind attention.
Thank you, Dr. Ferrari. And I would just take this moment to remind everyone to put your questions in the chat. And next, I would like to invite our final presenter, Dr. Florian Scher, who is joining us all the way from Germany. Dr. Scher is a PI at the University of Hospital Freiburg. His research interest focuses on developing non-invasive biomarkers that help improve the clinical management of cancer patients and understand biological factors driving hematological and solid malignancies. And today he's going to talk about his cutting-edge innovative research on non-invasive disease classification using circulating tumor DNA. And I'm personally really looking forward to this talk. Welcome, Dr. Scher.
Thank you very much for the very nice introduction, and thank you for inviting me to this awesome seminar today to present our work on circulating tumor DNA. So can you hear me? And can you see my slides?
Yes.
We can.
Perfect. All right, that worked. Okay, those are my disclosures. And the learning objectives. So I start with a very brief introduction on what cell-free DNA, circulating tumor DNA, and liquid biopsy in general is. So when cells die in our body, they release their DNA into the bloodstream, where it is called cell-free DNA or cfDNA. So those are tiny DNA fragments in circulation, and cell-free DNA that's coming from dying tumor cells is called circulating tumor DNA or ctDNA, which is a subset of the total cfDNA pool. And those are some cell-free DNA characteristics. They usually have a size of about 170 base pairs, which is one nucleosome rep, a half-life of about 2 hours. The concentration of cell-free DNA is about 5 nanograms per mil in healthy adults, but can be much, much higher in patients with cancer or non-malignant conditions like infection, inflammation, trauma, etc. And circulating tumor DNA specifically carries all types of genetic aberrations that we also find in the tumor, including point mutations, translocations, indels, chromosomal abnormalities, epigenetic changes, which makes it particularly useful in oncology with several advantages of circulating tumor DNA, including that it's non-invasively accessible, it's easily repeatable over time, and it has or reflects contributions for all tumor sites in the body, in contrast to single tumor biopsies. And that translates to these potential clinical applications of circulating tumor DNA in oncology, for example, early detection and tumor classification at diagnosis, response assessment and resistance detection during treatment, MRD monitoring and relapse prediction during treatment and during surveillance, and of course, prediction and detection of progression and relapse. So in our group, in collaboration with the ELISA lab at Stanford University, We focus on our work on aggressive lymphoma and specifically on central nervous system lymphoma, where we have several major clinical challenges. You heard a lot of them from the previous speakers. On the one side, we know that we have very heterogeneous outcomes following a methotrexate-based treatment, and that the prognosis is poor after relapse and progression. But the tools for accurate risk stratification and prediction of outcomes are largely lacking. And on the other side, we know and we heard from Dr. Kramer that diagnosis relies on invasive procedures that are often delayed due to concurrent steroid or anticoagulant treatment and are associated with perioperative risk, especially in elderly or frail patients and in case of deep cortical lesions or tumor manifestations in eloquent regions of the brain. So there's an unmet need for innovative biomarkers that facilitate the identification of patients at high risk for relapse or disease progression and for biopsy-free diagnosis of CNS lymphoma. And I brought two cases from our practice here in Freiburg in Germany that highlight the need for these biomarkers in these patients. So in case one, this was a female patient with a primary CNS lymphoma. You see the tumor here on the right side of the brain, who underwent 2 cycles of the matrix protocol, which is, as you heard from Dr. Ferrari, methotrexate, cytarabine, thiotepa, and Rituxan, and had a partial response according to the IPCG criteria, and received 2 additional cycles of this matrix protocol, but after these 4 cycles had a progressive disease. And the question is, can we predict progression earlier in CNS lymphoma, highlighted in this case? And the second case is also a female patient who had who was diagnosed with breast diffuse large B-cell lymphoma, got 6 cycles of R-CHOP, had a complete response, but then was admitted to the neurology department with headaches and abducens paresis, and of course is suspected of secondary involvement of CNS lymphoma, but MRI, flow cytometry, cytopathology of CSF, PET-CT was negative, so she was treated with steroids. The symptoms were getting better, but after tapering the steroids, the symptoms appeared again and again, received PET scan, several MRIs and CSF assessment, and still couldn't find out what the underlying disease is for those symptoms. So what do you do in these situations? And I'll come back to those 2 cases later. So circulating tumor DNA in CNS lymphoma has an advantage, and one of these advantages is that we have 2 compartments where we can detect circulating tumor DNA. One is the blood or blood plasma, and the other one is cerebrospinal fluid, CSF. But there are a lot of disadvantages compared to other malignancies in CNS lymphoma. So there are several limitations of circulating tumor detection in CNSL. For example, the ctDNA detection rates in plasma at diagnosis by NGS-based technologies is very, very low compared to, for example, systemic DLBCL or breast cancer or lung cancer. The detection rates in CSF are high, and monitoring is potentially possible, but CSF is, as you know, not routinely assessed during treatment or during surveillance. And there is a limited applicability of single gene assays like MIDI88, PCR assays, because MIDI88 is only present in 70 to 80% of lymphoma patients, or immunoglobulin VDJ rearrangement assays, which is often not detected. And of course, these single gene assays do not capture the genetic landscape. So in contrast to DLBCL and other malignancies, ctDNA has not been considered a clinically useful tool in CNS lymphoma for MRD detection, risk stratification, or outcome prediction. So our method or methodology to improve or to overcome this in collaboration with Stanford University was to use two next-generation sequencing tools that I just briefly mentioned here, which is CapSeq. It's a targeted capture NGS approach, and we designed a CNS lymphoma specific sequencing panel that captures about 580 genetic regions. And we used CapSeq for genotyping of tumor DNA and ctDNA from CSF and plasma. And we used PhaseSeq that was recently introduced by the Lisa lab at Stanford, which is particularly sensitive down to parts in a million ctDNA molecules, and that we used for monitoring of ctDNA in plasma and CSF. We analyzed various sample types, in total 306 samples in a study performed here in Freiburg in Germany. Tumor samples, plasma and CSF samples at diagnosis, plasma samples during treatment, and plasma and CSF samples at progression or relapse. We analyzed non-CNS lymphoma brain cancer controls and a bunch of healthy controls and applied these two technologies to all these samples. And I want to start with how we do with pre-treatment ctDNA detection and characteristics at diagnosis. But first start with tumor genotyping. So we started with genotyping 67 tumor samples at diagnosis. We found a median number of 288 mutations per patient. And as you can see here, the most frequent mutations or genes affected in this disease, as we all know, are MYD88, PIM1, CD79B, and in concordance with other previous studies, we found the MYD88 L265P mutation in 73% of the patients. So we take now these mutations in the tumor and monitor them in pre-treatment plasma and CSF. And we were able to, with PhaseSeq, with this technology, we're able to detect ctDNA in 78% of plasma samples and 100% of CSF samples, which was significantly better than the studies that had assessed ctDNA in plasma before through next-generation sequencing studies. And that was pretty interesting that we found, and reflects the actually biology of the disease. We found that the ctDNA concentrations in plasma were about 0.006%, which is really, really, really low, and almost 100-fold, 100 times lower than in CSF, which also reflects the different detection rates and the difference between CSF and plasma ctDNA detection. What was pretty interesting was that plasma ctDNA concentrations here on the left significantly correlated with the radiographic tumor volume assessed by MRI, and that was not the case in CSF. So ctDNA in CSF did not correlate with the radiographic tumor volume, but we see here in CSF that when we have periventricular involvement of lymphoma, ctDNA levels were almost 80-fold higher than in patients with no periventricular involvement. So we rather see that when we look at the CSF compartment, we look at in CSF, ctDNA rather reflects the localization of the tumor. And when we look at ctDNA in plasma, we see that ctDNA mirrors the tumor volume. And next, of course, we asked whether pretreatment ctDNA could be used for risk stratification and outcome prediction in CNS lymphoma. So here on the left side, you see that patients with positive ctDNA at diagnosis or before start of treatment had a progressive disease in 82% of patients, and 78% of patients died within 2 years. In comparison to that, patients with negative ctDNA before start of treatment only had 32% chance of progression within 1 year, and 10% died within 2 years. That difference was, in our opinion, pretty large, and that translates to these Kaplan-Meier curves and log-rank results, where we see that patients with negative ctDNA at diagnosis had a significantly better progression-free survival and overall survival than patients with positive ctDNA at diagnosis. That was also true in Cox regression analyses, both in univariate and multivariate Cox regression analysis, incorporating other risk factors, including the Karnofsky index, number of lesions, age, and we see that pretreatment ctDNA concentrations and the performance status both were independent predictors of progression-free survival and the overall survival. So we think that ctDNA might be a pretty strong biomarker for outcome prediction in CNS lymphoma in the diagnostic setting. Then in the next step, we also explored the role of on-treatment ctDNA measurements for risk stratification and MRD monitoring in this disease. And excuse me, for this question, we analyzed plasma during treatment in patients who receive curative intent therapies during the induction treatment, and we analyzed plasma in 2 groups of patients. One group was in complete response after induction therapy and consolidation therapy. Those were 11 patients, and 17 patients in the other group had progressive disease after or during treatment. We analyzed in total 49 plasma samples in these 28 patients, and we see in the upper group who had progressive disease, we see that 76, we find positive ctDNA in 76% of patients, while in the other group, who are all in complete response after treatment, only 9% of patients had positive ctDNA. That also is reflected by the log-rank analyses, where patients with negative ctDNA during treatment had a significantly better outcome than patients with at least one positive ctDNA measurement during treatment. So we come back to our case that I highlighted in the introduction. You remember this case who had a partial response but then progressed. And from this patient, we serially measured ctDNA during treatment. And you see here that between cycle 1 and cycle 2, the patient had a significant drop of ctDNA. But when we analyzed the plasma sample right before cycle 3, when the patient had a partial response by imaging, ctDNA concentrations increased and increased further towards the progression time point. And this would have led to an early detection of progression here between cycle 2 and cycle 3. And this patient probably could have, we could have spared some methotrexate toxicity in cycle 3 and 4 and changed treatment in this patient. Now we change gears a little bit and now focus on the question, can we identify CNS lymphoma by circulating tumor DNA? Dr. Kramer and Dr. Ferry have mentioned that it's possible to detect CNS lymphoma by ctDNA. And we think that this is particularly useful in certain scenarios in our clinical practice. So usually patients, as you know, patients present with neurological symptoms, have a suspected lymphoma lesion and MRI, and the standard of care is to have a stereotactic biopsy to confirm the diagnosis. But sometimes we have high-risk situations with tumor lesions in eloquent regions where stereotactic biopsy or surgery in general is not possible, or these patients receive a steroid or antiplatelet therapy where we have to delay surgery by 1 or 2 or even 3 weeks. And these situations lead to unconfirmed or delayed diagnosis of CNS lymphoma. And we think that the biopsy-free alternative would be really helpful, especially in the context or the background of having very low sensitivities of conventional methods like flow cytometry or cytopathology from CSF. So there are several methods for surgery-free CNS lymphoma detection that have been published. This is a table from a review published by Baraneskin et al. In 2021, which includes protein biomarkers like IL-10 or IL-6, MyD88, of course, or microRNAs. One study that I find especially interesting was from Andres Ferreri, published, I think, last year, which combines MyD88 L265P with IL-10. So we also do this here in Freiburg. We have established a digital PCR assay for MyD88 L265P for ctDNA detection from CSF, mostly CSF or plasma. We have established this assay in our lab that was also certified, so we can use that in routine practice. This certification is kind of the same thing that you have in the US, is comparable to the CLIA certification. And we apply this digital PCR assay in situations that I mentioned, in which stereotactic biopsy is delayed or cannot be performed. We have a turnaround time of about 1 to 3 days, and it's a pretty low cost technology. Digital PCR is pretty cheap, and it's very sensitive. And I want to show you one case that was a 60-year-old male patient treated at the University Hospital in Berlin, suspected CNS lymphoma in MRI, but the biopsy or surgery was not possible. And we received a CSF from the colleagues from Berlin and applied this assay and detected MyD88 at 265P at a very high concentration, actually, of 8%. And this patient was then treated based on these results with matrix and high-dose chemotherapy and had a complete response, which was also reflected in CSF post high-dose chemotherapy. So that's pretty helpful, but there is a downside. As I mentioned, about 30% of CNS lymphoma patients do not carry MyD88 at 265P. And because of that reason, we came up with a different strategy and tried to diagnose CNS lymphoma without surgical procedure and distinguish from other brain tumors based on the general ctDNA mutational profile in CSF or plasma using targeted NGS, overcoming the lack of MyD88, the specific hotspot in about a third of patients. And how we did that was we used a training validation approach. We trained mutational data from about 30 CNS lymphoma tumors and over 2,600 non-CNS lymphoma tumors from public data sets, and developed a machine learning classifier, which was an ensemble of Bayesian models to define a classifier score. And this classifier score distinguished, as I said, based on the general ctDNA mutational pattern and the ctDNA mutation frequency, CNS lymphomas from non-CNS lymphomas. And we applied this score on an independent validation cohort of 183 samples, 35 were tumor samples to benchmark the classifier. And we could predict the correct CNS lymphoma diagnosis in 97% of cases. When we go to CSF, we could correctly identify CNS lymphoma in about 60% of cases. And when we go to plasma, it was about 25% of cases, which again reflects the significantly lower ctDNA levels in plasma. And most importantly, when we apply the classifier to samples that come from non-CNS lymphoma cases, so GBM, metastatic cancer, astrocytoma, and so on, we do not find any positive result in this cohort, although we have to admit that these are only 16 different patients. So that leads to, as I said, a sensitivity in CSF of about 60% and the specificity and positive predictive value of 100%. And when we compare it to MyD88 265P alone, you see here that the sensitivity is a little bit better when we do this approach compared to the MyD88 assay. Okay, we come back to our second case. So the colleagues from neurology called us in this situation to analyze the CSF that they have obtained here from this time point. And we sequenced them with our approach and found a lot of mutations, actually lymphoma-specific mutations in PIM1, CD79B, MyD88. And the classifier turned out, or the classifier classified this sample as CNS lymphoma. And super interesting is that we would not have detected this with the digital PCR assay, with the L265P assay, because this was this patient had an atypical MyD88 mutation in V147L. So this patient was then transferred to our department, and we treated this patient with RDVIC. And we saw that the symptoms disappeared very quickly. And the patient received then high-dose chemotherapy and autologous stem cell transplant, and is still in complete response with no symptoms up to date. And you see here that the ctDNA concentrations in blue in the CSF went to 0 after high-dose chemotherapy, and we probably cured this patient with this strategy. So in conclusion, plasma and CSF ctDNA and CNS lymphoma is readily detectable in 78% of cases in plasma and 100% of CSF samples. It accurately mirrors tumor burden in plasma and it reflects the lymphoma localization in CSF. It's a strong prognostic biomarker at pre-treatment time points and during treatment, and facilitates non-invasive identification of CNS lymphoma in a large fraction of patients. We think that this might help to stratify CNS lymphoma patients into risk groups that might benefit from either a reduction of treatment to avoid toxicity or early treatment intensification. But of course, this is experimental at this stage, and it has to be proven in prospective trials. And allow surgery-free CNS lymphoma diagnosis or detection of occult CNS lymphoma, CNS involvement of aggressive B-cell lymphomas. With this, I want to thank my group in Freiburg, the collaborators at Stanford University, the CNS lymphoma study group in Germany, with which I work really closely with Gerald Illerhaus and Elisabeth Schorb, and of course, all the patients. Thank you for your attention. Happy to take any questions.
That was a great talk, Dr. Scherer.
Yeah, thank you so much, Dr. Scherer. We're at the end of the second session this morning. I would like to ask all of our discussants to please come back online and start your videos again, if that's okay. Dr. Chelsea Penix from MD Anderson had another obligation with another presentation after hours and will not be available for questions. There were two questions that were asked on the chat. This one is from Dr. Tim Fensky at the Medical College of Wisconsin and directed to you, Dr. Ferrari. Given the results of PRECISE and the IEL-SG32 with similar progression-free survival and overall survival with whole brain radiation therapy and auto transplant, and given that these trials used a higher dose of radiation of 36 to 40 gray, can we assume that auto transplant is superior? And perhaps with lower dose whole brain, might we be able to achieve identical results as auto transplant, assuming that a highly active induction regimen, such as rituximab, methotrexate, and temozolomide is utilized?
So thank you for the question. That is a really important question. It's not easy to give you a response with the available evidence. We can say that we cannot generalize the results of one trial and to consider that it could be used to draw the definitive conclusions on a similar strategy. When we speak about the different radiation doses used in the different trials, we have to take into account that the populations of the patients, the time where the randomizations were performed are really different in the trials and among the trials. And then I think that the main conclusion from the ELG32 is that both strategies are highly effective for the patients. And when they use the radiation doses, we can achieve 70% overall survival at 7 years in patients who achieve a response to matrix. In my opinion, a patient who achieve a response to induction, every type of chemoimmunotherapy induction, can achieve these results with radiation therapy or autologous transplant. The main difference with the French trial, other than the difference in the design, in the methods, the main difference is that a higher proportion of patients achieve the consolidation in response in the ELG32 trial, whereas there were a low response rate in the PRECISE to the induction in the PRECISE trial. Then this is an important difference at the time because it's probably that patients in partial response can achieve, can have more benefit from autologous transplant than radiation therapy. Regarding the low dose, the reduced dose to 23 grays in the whole brain, it's by the moment we don't have a randomized comparison with autologous transplant. It's probably that the results in this type of randomized trial may be similar to those of the ELG32. That is that radiation therapy with 23 grays can produce similar results to those achieved with autologous transplant. However, in my opinion, autologous transplant remains superior due to the lower rate of neurotoxicity, but also to the fact that can be repeated in the time, and also that there may be a lower rate of late effects in these patients. These are the main reasons why we prefer to offer autologous transplant to our patients. I don't know if in USA someone is thinking about to compare low dose, reduced dose whole brain radiation therapy with autologous transplant. It may be a possible design for a future trial. Conversely, in the meantime, we can consider that the ELG32 trial results allowed us to propose radiation therapy to patients who are not able to perform autologous transplant because poor mobilizers or with poorer conditions, or patients who refuse autologous transplant.
Very good. There was an additional question from Dr. Fensky that had to do with methotrexate dosing, Dr. Ferreri. Do you feel that there is any benefit for high-dose methotrexate doses greater than 3.5 grams per meter squared? He has had some experience with community oncologists using a dose that high, although in his practice, he's never, as a lymphoma specialist, he's never been convinced that doses greater than 3.5 grams per meter squared are superior. Can you comment on that?
So I think that there are two main limitations. The first one is that it's not able to. It's very hard to combine doses over 5 gram meter square of methotrexate with other cytostatics, and then it's difficult to propose to our patients a polychemotherapy with these doses. When you use methotrexate alone, doses of 8 gram meter square were associated with a need for dose reduction in half of cases. And then, in my opinion, 3.5 gram meter square is the best dose to be used in polychemotherapy. And by the moment, I think that nobody is using methotrexate alone. Obviously, in a patient who is suitable to receive a chemoimmunotherapy.
Very good. Thank you, Dr. Ferreri, for that excellent response. The next question is from Dr. Shireman here at UW-Madison. For Dr. Scherer, actually. How would you go about controlling for something like steroid administration, and how would it affect circulating tumor DNA load, irrespective of actual tumor growth or therapeutic shrinkage?
Yeah, that's actually a very good question. So we have some evidence, although the sample size is not big enough, that the ctDNA concentrations in blood plasma could be higher in patients who receive steroid treatment. You know, it's very variable. We have not explored that in a systematic way. At this point, we have samples from patients who receive steroids and patients who did not receive steroids. But the patients who receive steroids, you know, they're on steroids for 1 day, 3 days, a week, or 2 weeks. So it's not. I don't have any data. We don't have any data at the moment that systematically explore the effect of steroids. But we have some evidence, as I said, on a small sample size that steroid administration could increase the ctDNA levels in plasma and CSF, which makes sense, right? Because it kills the tumor cells.
On the same line, I have a question for you, Dr. Scherer. So MYD88 is a good mutation to profile these tumors with, but there are still tumors that are negative of that mutation. And for other tumors, primarily CNS tumors, that we're looking at DNA methylation profile for cell-free. Is that something that is also being explored in terms of lymphoma cell-free DNA world?
Yes, there are groups who are exploring epigenetic changes and to distinguish brain cancers based on the epigenetic changes. There has been some very interesting publications in the last few years focusing on glioma and glioblastoma, and it's obviously working to distinguish gliomas, lower grade gliomas from glioblastomas, for example. And there are some groups working on epigenetics. We are focusing on circulating tumor DNA and mutations and copy number variations, but I know that groups are working on that. And I guess I think it's pretty promising to go that path based on the data that we have from glioblastoma and glioma.
Perfect. For the folks who are still online, don't hesitate to post additional questions to the chat. I did have, and I'm hopeful she's still on, Dr. Chukwukwe. Is she still with us on the line? Or did she have to drop off? She had dropped off. Oh, good. Any other questions from our panel or to one another or from the folks that remain online?
I have a question for Florian. It's a pleasure to meet him again. What do you believe that it will be possible to perform these techniques in the intraocular fluids? Do you need a great amount of fluids to perform this exam, or do you believe that a few microliters are enough?
Yeah, that's an absolutely great question, Andres. We have some experience with intraocular fluid and with both the MIDI88 digital PCR assay and the next generation sequencing technology, and actually it works very, very well. Even with very few or little amount of fluid, and even with 200 to 500 microliters, it works very, very well. I guess because the concentration of tumor DNA, I think, must be super high in this compartment. And I think that's why the performance is good. So we have sequenced a handful of cases, and they were all positive, and the amount of DNA or the allele frequency of the mutation is super high. So it works very well.
And I guess along the same line, since Dr. Baraha is still online, how effective is the FDG PET at picking up like ocular disease?
Yeah, good question. PET imaging probably not as good as MRI would be in terms of sensitivity, right? We have spatial resolution issues with PET imaging just intrinsic to the physics of the radiotracer. So I think, as it was discussed earlier, vitreous biopsy can be needed to do that. I wouldn't be convinced at all that a negative PET CT would rule out ocular disease.
Very good. Any other questions? Well, I know that just in comments that I've gotten through the morning and having been a part of this discussion since the beginning, I can't thank our panelists enough. This has been just an amazing morning in learning about treatment updates and new paradigms in primary CNS lymphoma. I know Dr. Day and I are certainly ecstatic to have had such a wonderful group of international speakers join us today. It's just been fantastic, and we appreciate all of you for joining us this morning.
Yes, we would like to thank everybody for their presence and especially to our speakers who made this such a rich conference. I would also like to really thank Janelle for helping us get everything together and keep us in line, and also Chad for the technical assistance for everything.
Very good.
All right.
Yeah, we appreciate you guys. Just a
Thank you very much.
Yeah, one last bit of housekeeping. Don't hesitate for our American participants to put in the code for CME participation. And if there are any other questions or concerns, please don't hesitate to reach out to Dr. Day or I. Thank you guys so much for attending.
Yes, thank you again. And I hope this fosters a lot more collaboration amongst everybody.
Thank you so much, and thank you for the kind invitation.
Thank you very much.
Okay. Bye, Ramon. Bye, Florian.
Bye.